Everyone to the White Army EPIGNOSIS. We have with us our core mentor as a judge, Professor Veena ma'am from JIPMER, Pondicherry. She is a passionate teacher and mentor. Today ma'am is our judge for this EPIGNOSIS session. This EPIGNOSIS is a national level gynecology clinical case presentation competition where out of 50 members, seven members have been selected. So can we start the session, ma'am?
Sure.
Yeah, our first participant is Neha. Can you share the screen, Neha?
Yes.
All the best, Neha.
Thank you. Ma'am, is my screen visible?
Yes, screen is visible. Your voice is a little lower, actually.
Okay.
Little.
Is it better now?
Okay, go on. I can hear.
Yes, ma'am. My patient is a 60-year-old female who is a coolie by occupation, who has come from Chikbalapur from an upper-lower class family and was examined one day after admission. She came with the chief complaint of mass per vaginum since 4 years. Patient was apparently normal 4 years back when she had the feeling of something coming out and an abnormal feeling of pressure, which later progressed to mass protruding from her vagina, which further gradually progressed to the present size. The mass is increasing in size on straining and on coughing, and it reduces when she lies down. She also complains of a wound over the swelling from the past 2 weeks and bleeding from the wound in the form of spotting. She gives a history of lifting heavy weights as a part of her occupation. She also complains of difficulty in urination, which improves by splinting of mass inside. There's no history of increased frequency of urination, burning sensation while urinating, and no history of urinary incontinence on coughing and sneezing. There's no history of difficulty in defecation initiation, feeling of incomplete sense of emptying, incontinence, hard stool passage, or bleeding per rectum. There's no history of backache, pelvic discomfort, chronic cough, constipation, or smoking. Her menstrual history was unremarkable, and her obstetric history, she has 5 children, 3 of whom are living. The gap between each pregnancy was adequate. All of them were full-term vaginal deliveries conducted at home, and there was no instrumental use. She doesn't have any similar complaints in the past, and she's not a known case of diabetes, hypertension, asthma, epilepsy, or thyroid disease. And she's not been on any chronic drug use, such as steroid use. She's not had any history of blood transfusion and has undergone no surgeries in the past. There's no TB, diabetes, or hypertension in the family, and her mother had similar complaints but was not treated. Her personal history are all normal, except the bladder, which she complains of difficulty in urination, which improves by splinting of mass inside. She is moderately built and nourished, and she was examined after taking consent. The vitals were all normal, and patient is comfortable and cooperative. The thyroid, breast, and spine examination were normal, and pala, icterus, sinuses, clubbing, lymphatic node, and edema were absent. Systemic examination were all normal. On inspection, the shape of the abdomen was normal, umbilicus was central, stria albicans was seen, there was no distended veins, sinuses, or visible pulsations, hernial orifices are intact, there are no visible swellings, and all quadrants moved equally with respiration. On palpation, the abdomen was soft, non-tender, and there was no palpable mass or organomegaly, and abdominal tone was good. On percussion, there was no evidence of fluid accumulation, and on auscultation, bowel sounds were heard. I would like to do an examination of external genitalia and bimanual examination to complete my examination. To summarize, here is a 60-year-old postmenopausal woman, para 5 living 3, coolie by occupation, comes with chief complaint of mass per vaginum since 4 years, which has progressed to the present size. Mass is irreducible and increases with coughing and straining. It reduces on lying down. She has difficulty in micturition, which improves on splinting the mass. She also gives a history of lifting heavy weights as part of her occupation, and also has a history of wound over the mass. My provisional diagnosis is that she's a 60-year-old postmenopausal woman, para 5 living 3, with genital prolapse and wound over the prolapse.
Okay,
Thank
good.
you.
Presented well. The thing is, examination you guys are not doing?
Ma'am, we have not supposed to do vaginal and
Not vaginal, at least the inspection of the prolapse.
no, ma'am, we didn't do that.
Fine, fine. In exam, probably they will give you some kind of findings. Let's assume this is a third degree uterovaginal prolapse so that we can go ahead with the discussion. But anyway, you started with age of the patient. Okay.
Yes.
Go back to the first slide.
Yes.
Okay. How old is the patient?
She's 60-year-old.
So what is the, when a patient presents with mass descending for vagina, that's what it is actually, or mass coming out of the vagina in patient's words. Okay, so what exactly should come to your mind? Why is age important in that scenario?
Ma'am, with increasing age, the risk of prolapse increases because the protective action of estrogen comes down after menopause. Also, with age, the lordosis of the spine also decreases. So that's the protective action of the lordosis.
It's a very minor thing. The most important thing is that there is estrogen deficiency, which leads to asthenia of the pelvic tissues. Okay.
Yes.
But what is the most important factor in genital prolapse?
It generally happens in a multiparous postmenopausal woman.
Multiparous, yeah. That means the previous obstetric injury. Okay. So now you told me that as age increases, you have the increased risk. Tell me, can't we see prolapse in younger age groups? Don't we see prolapse in younger age groups?
Yes, ma'am, we can see, and generally they would be like because of connective tissue disorders.
Okay, the congenital prolapse where there is ligament laxity, and sometimes we do see it in younger women after one delivery, right? So not that, even though the most common age is postmenopausal, we can see it in earlier ages also, and your management depends upon the patient's age. That's what is most important. Okay.
Yes, ma'am.
Now, you told me her urinary symptom is only one, right?
Yes,
I asked about some backache. Why do they have backache? Why did you specifically ask for backache?
Ma'am, because of the stretching of the uterosacral ligament, the nerves can get stretched, which can lead to lower back pain and prolapse.
How exactly will the back pain be? When is it more? Is there any diurnal variation?
Ma'am, I'm not. I think it would be more when the prolapse is more visible. Like if she's lying.
Diurnal variation. Diurnal method in a day. When is pain going to be maximum?
Ma'am, it would be maximum towards like the end of the day, but it would be minimum when she wakes up.
When she sleeps in the night, the prolapse is not dragging. There is no gravity acting on it, and her pain is minimum in the mornings, and it increases as the day progresses. Okay.
Yes.
Now tell me, what else will you think of other genital prolapse? You've not even examined the patient. You just know that it is a thing. In this age group, what else can you think of?
It could be a polyp. It could also be a rectal prolapse. Then it could also be a growth like a carcinomas or malignancy.
Carcinomas and all don't come out of the vagina, right? Generally,
yes,
when we say mass descending for vagina, it is something coming out of the vagina. It's not something which is growing on the genitalia or a growth which is coming up. It's not like that. Okay.
It could be chronic uterine inversion.
Yeah, in this age group, we'll also think of that, but they're all extremely rare. So one thing which comes to mind is genital prolapse. Now, irrespective of age, mass descending for vagina, what else should come to your mind?
Polyp, like fibroid polyp.
Polyp to fibroid polyp, okay. What else?
Then it could, ma'am, it could be like a rectocele, urethrocoele.
Individual components alone may be there. That's good. Then anything else?
Then
congenital elongation of cervix.
Oh yes, ma'am.
Vaginal elongation.
Congenital.
Do not miss that, because that's a very important differential diagnosis with genital prolapse. This we see generally in younger women, okay, around 20s, 30s. Probably they'll manifest after one delivery. Okay.
Yes,
other than that, one more important differential diagnosis, which is actually a DD for cystocele.
Ma'am, it could be a cyst in the anterior vaginal wall.
Okay, so these are the different things should come to your mind. When you examine, you will know that, okay, this is genital prolapse. Because the most common thing is genital prolapse, you don't really bother. But sometimes we should not assume it's genital prolapse and go ahead. For example, you have an anterior vaginal wall cyst and cystocele. It's very important between these two. The treatment is entirely different, right? Okay, now go to the obstetric history. Yeah, so what do you think contributed to the development of prolapse in this lady, looking at this slide?
Ma'am, she is multiparous. She has had 5 children. And
Most
then
important is she
also
got multiple vaginal deliveries. Okay.
multiple and they were all conducted at home by a dye. So that would also contribute to the
How
risk.
does home delivery by an untrained dye contribute to development of prolapse?
Ma'am, it could be like improper management of the labor. Like there could be like the improper management of the first and second stage of labor.
Like, give some examples. What exactly do dyes do which we don't do in institutes, hospitals?
Yes, ma'am. In the there could be premature bearing down, and there could be fundal pressure which was applied during the second
Dyes
stage.
don't have any knowledge.
There could
of
be
first stage, second stage.
very late.
Go on.
Yes. Then there could have been episiotomy which was applied too late, which was performed late, and which caused.
They don't perform episiotomy at all. Dyes don't perform episiotomy. Okay.
Yes, ma'am.
That leads to Delancey's level 3 problems. There will be a lot of undue stretching of the perineal areas leading to Delancey's level 3 problem, leading to rectociliary deficient perineum. Okay.
Yes.
Otherwise, generally, untrained dyes do not have any knowledge about first stage, second stage of labor. They'll just look at the sun. Okay, did the sun set twice over this lady? Did the sun rise twice over this lady? That's what they think when the woman goes into labor. And they'll ask her to bear down. That's all. They'll start giving fundal. They'll bear down. Even if she's in first stage, it will go on. So generally, these problems will lead to Delancey's level 1. The uterosacrals and Macken rods will get unduly stretched because it is pushing the cervix down over here in an undirected cervix. Okay, that's the importance of your obstetric history. Okay, the untrained dyes thing. Okay, now that you have, how do you say it is cervix, by the way? Something is lying outside the introitus. How do you know it is cervix?
The external os will be visible. Like
the most important thing is that opening. The os is the one which tells us this is cervix which is leading down. Okay, you should also tell about the leading part of the prolapse. So the examination of prolapse is actually important. You should have done it. I don't know what's the system in your college, but we expect students to see the inspection at least.
Okay.
Yes. Because you are telling there was an ulcer wound over the prolapse is what you presented, right? What wound can it be?
Ma'am, it could be like a decubitus ulcer.
Why do decubitus ulcer occur in prolapse?
Ma'am, there'll be venous congestion. So that causes like a trophic ulcer in the lowermost dependent
How do you
part.
treat it?
We take a gauze and it's dipped in antiseptic, and then the uterus is packed. It's reduced and packed inside.
Basically,
and,
you have to reduce the prolapse. Okay.
Yes, ma'am.
Fine, good. Now, coming to how do you want to investigate this patient?
Ma'am, I would like to first do investigations to check like a complete hemogram. Then I would want to do a CBC. I mean, I would want to do a blood sugar estimation. Then I would want to do a urine investigation, and I would like to check her hormone levels, like thyroid hormone.
What exactly are you looking for in the urine examination?
I'd like to check for urine sugar and proteinuria.
That's all.
Ma'am, and she could have, and I would like to see for cells like white blood cells and all, to see like if there's bacteriuria.
Why bacteria thinking of?
She's at a risk for cystitis and urinary.
That should be in your mind. We do a urine culture along with the urine routine microscopy. You should also do a urine culture surely in this lady. Okay, what else will you do before you take up for surgery?
Before we take up for surgery, we have to get the fitness done. For that, ECG, then
specific for us gynecologists.
We'd like to do a pap smear before we do a surgery.
Don't forget a pap smear and the gynecological investigations when you're telling. These two are specific. Other than the urine culture and pap smear, everything else is same as for any other gynecological or surgical case. For the anesthetic fitness and for checking out her comorbidities, we do all those investigations. But you should never forget a pap smear and this thing. Okay. And what exactly you want to do for your patient?
Since my patient is 60-year-old, I would prefer to do a hysterectomy along with pelvic floor strengthening. So that was the, yes, ma'am, I would like to do that.
Okay, it depends upon what component she has. Okay,
yes. Does
she have a rectocele? Is it deficient perineum this patient? Okay, does she have a cystocele? All these things we have to look at and repair accordingly. Generally, I don't know what you guys call it. We call it as ward Mayo surgery.
Yes.
The name of the surgery is a ward may use, which includes vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineurophy. Instead of telling pelvic floor strengthening, you better tell the components like this. Okay.
Okay.
Tell me, what are the components of anterior compartment relaxation?
In anterior compartment, we could have in the upper 2/3, there could be a cystocele, and in the lower 1/3, there could be a ureterocele.
Okay. Posterior compartment?
The posterior is divided into 3. So the upper 1/3, there can be the pouch of Douglas, that's an enterocele. In the middle 1/3, it's the rectocele, and the inferior 1/3, it's a lax perineum.
Okay. Actually, enterocele is not counted as a posterior compartment at all. Posterior vaginal wall is different, compartment is different. Okay.
Okay.
So this enterocele, along with the uterus, comes in the central or apical compartment.
Okay.
Okay.
Yes.
The causes which lead to the three things are different, and we know that the enterocele, the pathology is going to be same as your uterine descent. Okay. So, have you seen any prolapse surgery being done?
No, ma'am, I haven't seen.
You have not seen. Okay. What do you think could be the complications of prolapse surgery?
There could be complications during the surgery, immediately post-op, and then after that. During the surgery, there could be anesthetic complications and primary hemorrhage, and there could be damage to the surrounding structures like the rectum or the bladder. Then after the surgery, there could be reactionary hemorrhage, and there can also be, there would be difficulty in voiding, and there could be buildup of urine. Then there can also be, yes, ma'am.
Okay. How much time do we have left? Organizers?
Yes, ma'am.
Should I
Yeah,
keep the time myself, or somebody will
it's
update
time
me about the time? How
It's
much
time
more
up.
we have?
Yeah, it is actually 5 minutes, ma'am, for discussion.
No, I'm asking you how much time we have. We have totally another 5 minutes left. Right?
Yeah, ma'am.
Okay, fine. Neha, this patient is not willing for surgery, or she's not fit for surgery due to some problem. What else? What are the other options for us?
Ma'am, if she can, I mean, if she's not fit for surgery at all, then we would have to do insertion of pessary. Yes, ma'am, that will help prevent the prolapse from.
The prolapse is very huge, procedentia. Your pessary is not going to help. What other options do we have?
Ma'am, if she can handle a little amount of, I mean, little duration of asthma, then, I mean, little duration of anesthesia, then Lefort's surgery can be performed, where the vaginal is completely closed, so that.
We'll never close the vagina completely. What about the discharge, whatever comes from?
Yes, so not, I mean, yes, ma'am, not completely, just so that the prolapse.
Raw area in the anterior and posterior vaginal walls, and we only close that, so that the side there are 2 tunnels to allow. Okay. What is one prerequisite we have to have surely before doing Lefort's?
Ma'am, it should not be a young patient.
Obviously.
And, yes, ma'am, and it should be postmenopausal, because there shouldn't be buildup of menstrual blood, and there shouldn't be any infections or.
See, once you do Lefort's, your access to cervix is going to completely close off. So you have to be 100% certain there is no survival.
No.
The pap smear, normal pap smear is a very important prerequisite before we do a Lefort's. Okay. So now one last question to you. If this patient was 25-year-old Paravan Liven, okay, with 3rd-degree prolapse, what are the options available for us?
Ma'am, if she's still planning to
have one more baby,
then we could go for sling operations.
Sling operations in a Paravan Liven?
Uh,
Is the cause in this lady going to be a congenital weakness of the ligaments or something else?
Ma'am, it could be other causes like elongation of, I mean, congenital elongation of cervix. In
What
that
surgery
case,
is available for us in that scenario?
ma'am, then we can do the Fothergill surgery, where we amputate and decrease the length of the cervix.
Amputate the cervix. There's only a part of the surgery. There are many other things. It depends on whether she has a cystocele, rectocele, and all those things we have to look at again. Okay, because she undergone a delivery, she might have had some vaginal relaxation also. So we have to see all that and then take a call. Manchester surgery itself has many other components. Ambulation of cervix is only one component of it. Okay. Good, you presented well. You seem to know some subject, but I would have been happy if you had at least told some findings, because examination, I don't know how much marks to allot to you. There is nothing in the examination in this particular case for us. There is an abdominal mass, I can understand. Right, you would have presented something, but here without even inspection, it becomes difficult. But it depends upon your individual institute's, practices. But otherwise, good.
Thank you. Thank you.
It was good, Neha.
Thank you.
Yeah, our next contestant is Ms.Shwetha. Are you ready, Ms.Shwetha?
Yeah.
Yeah, present your case.
Hello, ma'am.
First, you people introduce yourself. No, Neha, I didn't get where you're from.
Ma'am, I'm from Bangalore Medical College.
Okay.
Thank you.
Yeah, ma'am, I'm from Lokmanya Tilak Municipal Medical College, Mumbai.
Mumbai, ठीक है.
Yeah.
ठीक है. Start करो. Share your screen.
Shwetha, share your screen.
Yeah.
Yeah, start presenting. Your time starts now.
My patient name XYZ, 24 years old female, resident of Gardgopar, Mumbai, is a teacher by profession, belongs to the lower middle class as per the modified Kupuswamy scale. She is unmarried. Her last menstrual period was on 7th April 21. Date of admission was 20th April 21 and date of examination was 23rd April 21. She came with a chief complaint of heavy menstrual bleeding and painful menstruation since 6 months. Patient was apparently at 6 months back when she developed painful and heavy bleeding. It was insidious in onset and progressed gradually. It was dull aching in nature and in lower abdomen, and there is no history of any pain radiating to the lower back or thighs. It began 3 to 4 days prior to menstruation and continued throughout the bleeding period and sometime after. It does not reduce on taking medication. Patient also complains of heavy menstrual bleeding since 6 months. She uses 6 to 8 sanitary pads per day. She also complains of waking up at night in order to change her pads. No history of abdominal mass, no history of constipation, no history of painful defecation, no history of intermenstrual bleeding or fever with chills, no history of painful urination or increased frequency of urination, no history of vaginal discharge or easy bruisability or evening rise of fever, significant weight loss and cough. Based on her previous menstrual history, she attained menarche by 12 years of age. Her menstrual cycle was regular for 28 days and bleeding occurred for 4 to 5 days, which was normal and not associated with pain. She used 3 to 4 sanitary napkins per day and no history of passage of cloths. There is no history of past history. There is no history of medical intervention, no history of diabetes, hypertension, tuberculosis, thyroid disorder, asthma, and no history of any surgery. Personal history, she consumes mixed diet, appetite is normal, bowel and bladder habits are normal, adequate sleep, and no history of any addiction. Family history, there is no significant family history. There is no complaint of any hypertension, tuberculosis, asthma, diabetes, or malignancy in the family. To summarize, 24-year-old unmarried lady with no comorbidities and no significant past history came with the chief complaint of painful heavy menstruation since 6 months, which is in the lower abdomen and not relieved by medication. On general physical examination, the patient is conscious, cooperative, and well-oriented in time-place person. She is moderately built and nourished, weight 52 kg, height 156, BMI 21.3 kg per meter square. Pallor was present, no icterus, no cyanosis, no clubbering, no generalized lymphadenopathy, and no generalized edema. Temperature was she was afebrile. She had a pulse rate of 72 beats per minute, regular rhythm, normal volume, no vessel wall thickening, and no radiofemoral delay. Respiratory rate was 18 cycles per minute throughout abdominal. Blood pressure was 130 by 80 and was taken from the left hand in sitting position. On inspection, the shape of the abdomen was flat, position of the umbilicus was central and inverted, corresponding areas move equally with respiration. There was no scars, sinuses, dilated veins, hernial orifices were intact. No local rise in temperature on palpation. Tenderness was present in lower abdomen in the iliac region on both sides. Abdomen is soft, there is no palpable mass felt and no organomegaly. On percussion, tympanic note was heard, liver dullness was heard at the right fifth intercostal space. On auscultation, bowel sounds were heard. On systemic examination, cardiovascular system, respiratory system, and central nervous system were normal. And on provisional diagnosis, 24-year-old unmarried lady who came with a chief complaint of painful and heavy bleeding since 6 months with tenderness in the iliac region on both sides is probably a case of endometriosis.
Okay. So her chief complaints are heavy menstrual bleeding and dysmenorrhea, right?
Painful bleeding, yeah.
So what type of dysmenorrhea do you think this is?
Ma'am, it is mostly secondary dysmenorrhea.
Okay. What's the name for this? What are the different types of dysmenorrhea we have?
Okay, so there are 2 types basically, primary and secondary. And clinically, if we see it, it is like spasmodic, congestive, and membranous.
And
membranous.
We can also have a mixed variety, and we can also have something called as triple dysmenorrhea.
Yeah.
Okay. In a case of endometriosis, we generally expect that they'll have triple dysmenorrhea. In pure congestive, how will the history be?
Sorry, ma'am, can you
In
repeat?
pure congestive dysmenorrhea, what's going to be the history?
Okay, so in congestive dysmenorrhea, it will be like the pain will start a few days before the beginning of menses. It will continue during the period and mostly throughout the
pure
period.
congestive dysmenorrhea, moment the bleeding is well established, the
Yeah.
pain disappears. The pain is not.
Okay, yeah.
Okay. The mixed variety, they'll have pain ongoing during menstruation also, other than the 3-4 days prior to menstruation. And the triple dysmenorrhea is they'll have bleeding. I mean, the pain even after bleeding stops,
Yeah.
before, during, and after. That is very typical of your endometriosis because the capsular stretching stays for some more time. Okay.
Yeah.
So your patient is basically a case of AUB, okay, with complaints of dysmenorrhea. Moment you have a congestive dysmenorrhea, what can you rule out? What's the most common cause of AUB according to you?
Okay, most common cause. I think it is endometriosis. Ma'am, I'm not sure actually for that.
The most common cause is ovulatory dysfunction.
Okay.
Okay, all the anovulatory DOBs, what we see, they are the ones which account for almost 40% of cases of AUB. Okay. Following that, we can have any of these PALM. You know the PALM point classification?
Yeah, yes, ma'am.
Okay. So what is the main difference between the causes which come under the PALM and the causes which come under the POEM?
Ma'am, so in PALM, they are mainly structural defects, which is leading to the, as in the AUB. And in the other one, it is the functional defects.
Functional or non-structural defects. Basically,
Defects.
there is no palpable pelvic pathology in the POEM, but in PALM, we should be able to make out some pelvic pathology, either on clinical examination or sometimes on imaging. Okay. So this patient is, you think it is endometriosis, right?
Yes, ma'am.
What could be the other causes in a slightly older lady, not in this young unmarried girl? Later on with the same symptoms, some multiparas, para 2, like 2, 35, 40-year-old lady comes with this kind of symptoms, what will you think of?
Ma'am, mostly it is adenomyosis in like increased age.
What is adenomyosis?
So adenomyosis is basically the endometrial tissue growth inside the myometrium, or the stroma and the glands.
Both the stroma and the glands grow inside the myometrium, where they're not supposed to be, which leads to undue stretching of the space over there. It's a restricted space. It's not a space where they can grow uninhibited, right? Okay. First of all, in any case of AUB, what's important is how do you know she's surely having heavy menstrual bleeding?
Okay, so we can ask her like how many pads does she change in a day? And like if it is more than what she used to do previously, so that way we can compare.
What was this patient's previous menstrual cycles?
So like she had normal bleeding. There was no heavy bleeding, no pain, and she normally changed like 2 to 3 pads per day. But then eventually she started using like 6 to 7 pads, changing like 6 to 7 pads per day. And then there was pain, and yeah, and then again that and it gets heavy bleeding.
Okay. So basic thing is just the number of pads is not going to help you. You have to compare how many pads she was using prior to this onset of symptoms. Okay, she was using 3 to 4. Now she's using 6 to 7. It indicates. Otherwise, if you have to objectively say, how do you say that this patient is a case of heavy menstrual bleeding? How many ml of the blood is normal during normal menstruation, and more than what is taken as heavy menstrual bleeding?
Okay, so normally it's like around 20 to 80 ml, but then anything more than 80 ml indicates heavy bleeding.
Yeah, because we do not use menstrual cups so commonly in our country, it's very difficult to quantify the amount in ml like this objectively. So we just look at the number of pads. Anything else? What else you look at to say she's a case of heavy menstrual bleeding other than amount of bleeding?
Ma'am, so like, can we look at her hemoglobin levels and stuff? Like
that is different. By history, we're just going by history right now, not investigations. Okay. In the history, what else will tell you? Yes, she's surely a case of heavy menstrual bleeding. Number of days.
Oh, okay, yeah. The number of days she bleeds for.
If she's bleeding more than 8 days, then you know that it is surely heavy menstrual bleeding. Normally, we don't expect them to bleed for more than 8 days. Somewhere on an average is going to be around 5 days, plus or minus 2 days. But if they're bleeding for 8 days or more, then it will become heavy menstrual bleeding. What else will tell you? See, there are a few things in history itself which will tell you, yes, she is suffering from heavy menstrual bleeding. Okay, so you should know how to distinguish, because sometimes women subjectively feel that yes, I'm having heavy menstrual bleeding, but to start the evaluation, we have to be certain that it is truly requires further evaluation. So we look at all these things. we have to make sure that yes, she is having heavy menstrual bleeding. Right? So what are those? Another two things I want. One is the amount of bleeding, number of pads. Other one is the number of days she bleeds. Other one is Shwetha, come on.
Okay, so
Is she passing clots?
okay,
Okay, what's the significance? If the patient is telling, I never used to pass clots before, but nowadays I'm passing clots during menstruation, what does it indicate?
So it indicates like the bleeding is really heavy because inside the endometrium there is this clotting mechanism, as in
Not clotting mechanism.
no, the fibrinolytic mechanism. Yeah, so the fibrinolytic mechanism prevents it from clotting, but then since the bleeding is very heavy, it just gets diluted and doesn't work properly, and then it starts forming clots.
Not
And then
like that.
coming.
The amount of fibrinolytic enzymes present is fixed, okay, which are enough to lyse the normal menstrual blood, the normal amount, okay. But moment the bleeding is more, there is no proportionate increase in the fibrinolytic enzymes over there. So part of the blood is fluid, and the rest of the blood, which is beyond the purview of the enzymes present over there, will come out as clots. Okay. Then the last thing is, you should be telling this one now. What's another thing which will tell you it is heavy menstrual bleeding? You told the investigation. What are the symptoms of anemia?
Okay, so easy fatigability.
Yeah. If she's really bleeding, you know that she would have developed anemia. Obviously, if she's really having heavy menstrual bleeding for a long time, like 6 months and all, she would have lost a lot of blood, right? So they'll present with systemic symptoms of anemia like easy fatigability, tiredness, malaise, lethargy, all those things will be there. Okay. So that is how we'll know that yes, this patient is truly having heavy menstrual bleeding, and we need to evaluate her further. Okay. That's what is very important. Okay. So now go back to your next slide. She's an unmarried girl, right?
Yes, ma'am.
Okay. Keep going. Keep going. You told there is no painful defecation.
Yeah.
Right? She's 24 years of age. Don't assume she's not sexually active. You have to ask her, or let's assume, let's not be too scandalous over here. Let's assume she's a married lady. What are the symptoms will you ask? Which is very typical of.
Ma'am, we'll ask about any pregnancy that could have led into abortion and led to heavy bleeding and menorrhagia. Okay, and IUCD uses and
Not for this thing. I'm asking about endometriosis specific symptom in married women.
okay.
See, endometriosis generally will lead to what is the most common symptom of endometriosis?
It is the pain, the pelvic
Dysmenorrhea.
pain.
That's it. Dysmenorrhea is the most common symptom of endometriosis. Okay. And if the patient is having heavy menstrual bleeding, it indicates that there is increased vascularity of the pelvic tissues. That's why they're having heavy menstrual bleeding. Generally, that's how it is. But remember that all these conditions are hyperestrogenic states. So hyperestrogenic states, all of them will lead to some amount of endometrial hyperplasia also. Okay. That's why they present with heavy menstrual bleeding, other than the congestion which occurs in endometriosis. Okay. So what I'm asking you is, what are the symptomatology of endometriosis?
Okay, so it is this menorrhea, dyspareunia, and
is what I was asking you. Married lady will surely ask about. She's not leaving me. My maid here. Tell me. Okay, so dyspareunia and all those things are important. Okay, so this lady is unmarried, so don't assume that she may not be sexually active. Please ask about that symptom also if she's sexually active. Okay, so that's one more important symptom we should have mentioned somewhere, but because she's unmarried, it didn't bother, I think. Okay, what else? What I was asking you was, if the patient is having congestive dysmenorrhea, we rule out all the Coin causes. Please remember that. Congestive dysmenorrhea will generally occur only in farm conditions, the structural causes condition. Anniversary dubia and all are not going to have any kind of dysmenorrhea at all. Okay, so that's very important. Moment you have a congestive dysmenorrhea, you know that okay, we're dealing with something structural. Okay, what kind of findings do you expect? If you have to do a bimanual examination, what are going to be the findings? Per abdomen, there is nothing right in this patient. No positive finding in abdomen.
Yeah.
Okay. We don't expect also because endometriosis is a painful condition. They come to us pretty early. Okay. We'll get the abdominal masses only when the patient is not having painful conditions. Pain is something which human beings can't tolerate, right? They will approach the doctors early if there is some symptom of pain. Okay. So tell me if you have done a bimanual in this lady, bimanual pelvic examination, what findings do you anticipate?
Ma'am, so
uterus is going to be normal? most probably uterus will be normal size. Okay.
Yeah.
Then,
Ma'am, so now should do I have to say, like, what are the findings in endometriosis, right?
Yeah.
If I do a bimanual palpation.
yeah.
Okay, so it will so first of all, uterus will be normal, and then in case of suppose if it has invaded the rectum or the colon, so maybe I might feel a mass or something.
Even if she's not invaded in the beginning stage also, this lady doesn't have any symptom of your dyschezia and all this stuff, right? So what do you expect?
Okay, so if at all there is any adnexal mass, maybe I can feel that.
No, that there are going to be adnexal masses. Describe the adnexal masses.
Despite that,
oh, tell me one finding you will get when you do a bimanual in a lady with endometriosis. Shwetha, if there is pain, if pain is a predominant symptom, what sign will you get in pelvis? What is the complementary sign of symptom called pain?
Tenderness, okay.
Okay.
Sign. Okay.
The adnexal masses, even if you had told me tender masses, I would have been happy. Okay. So remember, whenever there is a pain, significant pain symptom is there, you'll expect tenderness in the pelvis. If that is the cause of the pain. Okay. So that is what we are going to worry about. That's how we diagnose actually endometriosis. There are very typical symptoms. The cysts are going to be firm to cystic. Okay, number one. Okay, cystic to firm or firm to cystic because they are thick-walled cysts and they'll be tense. So sometimes you may even appreciate them as firm. Okay. Other than that, we can also have, fixity of the tissues because endometriosis will have restricted mobility. Okay, they're not going to be freely mobile masses like other benign ovarian cysts. Okay, and we can also find nodularity on the uterosacrus. Because even though the ovaries are the most common site of endometriosis, extrauterine, like when you look at the thing, what do they call these endometriotic cysts? What's the other name for them?
As in the ovary, it is called as chocolate cyst.
Chocolate cyst, because the contents look like chocolate. I'll keep talking. I'm just switching off my video. Okay. Yeah. Tell me. Then you have. Okay. Yeah. Can you hear me now?
Yes, ma'am.
Yeah. So you have diagnosed endometriosis clinically. You think it is endometriosis. How will you confirm a diagnosis?
So we can start with doing USG. So that might
USG?
show. Sorry, ma'am.
What USG?
Transvaginal USG.
According to you, she is nulliparous virgin lady, right?
Yeah, but ma'am, if at all there is like ovarian involvement.
See, in a virgin girl, we can't do TVS. Okay, remember that. Always unmarried when you're telling us, don't assume that they're sexually active like I told you. So you have to make sure that only if you have found that hymen is not intact and she is telling history of intercourse, only then you can do a TVS. TVS, of course, is the right investigation in a married woman for this particular thing, but you have to remember that a patient is an unmarried girl, probably a virgin, for all we assume. So a TVS is not possible. If TVS is not possible, what else can we do?
Can we do like a diagnostic laparoscopy?
No. Ultrasound. First investigation is ultrasound. Just because TVS is not possible, it's not like we won't do ultrasound. We will do an abdominal ultrasonogram with the full bladder. Because pelvis is not very easily accessible in abdominal ultrasonogram. We need an echogenic window. Okay, so that window which is going to provide the visualization for us is bladder. Okay, so we'll ask the patient to be full bladder and then we look at the pelvic tissues. Okay, describe how do endometriotic cysts look on ultrasound.
Okay, so endometriotic cysts, they basically appear like a black background with multiple white spots, like the echoic spots.
What is a typical description of this cyst?
Description as in
thick-walled with ground glass appearance is what they are described as. Okay. How do you want to treat your patient now?
Ma'am, so first we need to take care of the menorrhagia because so we can give her oral hemantinics and to take care of anemia as required if she has it, and then if then we can start with, since she's unmarried and so we can't give OC pills, so we can start with NSAIDs and tranexamic acid.
Why you can't give OC pills in unmarried girls? Huh? What kind
No,
of
so like in the
misconception is,
sorry, ma'am?
what kind of misconception is that we can't give OC pills in unmarried?
No, like initially, like we can start with this and then we can start with OC pills and then progesterone and then
What do we start with initially before OC pills? I didn't get it.
no, like we can just start with NSAIDs and tranexamic acid.
Yeah, obviously, always the first line of treatment in AOB is going to be your NSAIDs and antifibrinolytics. Okay, but that is not curative, or it's not going to take care of the problem. What it does, it just acts as symptomatic treatment. Like you give a paracetamol for fever. And if the cause of fever is UTI, till you give antibiotic, it's not, you're not taking care of the problem itself, right?
Yeah.
So, see, endometriosis is not a curable disease, please remember.
Yeah.
Once they have it, they have it. Whether we give OC pills or NSAIDs or whatever, it is going to be like there. We have to keep on, we can only control it. We can never cure it. Okay. So, to control the symptoms as such, we can use painkillers like NSAIDs with antispasmodics for the dysmenorrhea, and we can use tranexamic acid with mefenamic acid for menorrhagia. That is fine. But other than that, what are the other hormonal treatments available for endometriosis?
So then we can start with hormones like OC pills. And if suppose she has
OC pills, how will you give OC pills in this lady? You're advising OC pills. So how do you give OC pills?
Okay, so we'll just ask her to start it from like the 3rd day of her menstrual cycle, and then she'll take it for 28 days and then a break of 1 week.
No pill is available for 28 days. It's only available for 21 days with 7 days pill-free gap. Okay, but what I'm asking you here is, it's not the same way the way we give OC pills for contraception in endometriosis. Okay, here it is preferable to give something like seasonal. What is seasonal?
Yeah, so seasonal is also a combined OC pill which has estrogen and progesterone.
I don't get it. Your voice suddenly is becoming lower, Shwetha.
Hello? Hello?
Yeah.
Can you hear?
No, it's very low. Suddenly it becomes low. Suddenly the voice increases. I don't know whether only I'm having this problem.
Sorry to interrupt. Shall we stick on time, ma'am?
Yeah, sure. I'll wind up. 1 minute.
And one more request, ma'am. I had requested the participants only to do it in the UG level, ma'am. They are not, most of them not included in per-rectal and per-vaginal examination. So please consider that, ma'am, please.
Yeah, sure. Okay.
Thank you.
Hello, ma'am. Can you hear me?
Yeah, now I can hear you.
Yeah, so ma'am, OC pill is basically, it has estrogen and progesterone. We give it for like 21 days and then we give a break of 6.
Okay, fine, Shwetha. I think we'll close it. Doesn't matter. Okay, chalo. Good. Next candidate, please.
Yeah, ma'am, I would like to clarify, ma'am. It's 5 minutes case presentation and 15 minutes discussion, ma'am.
Yeah, totally 20 minutes, right? This was 21 minutes. That's all. Only 1 minute I went ahead.
Yeah. Yes, ma'am. Yes.
Okay.
Our next
I
participant
went
is,
extra because I took some time. My maid was
okay. It's okay, ma'am. It's okay. Our next participant is Vishwa Mehta. He's a 3rd year MBBS student from Gitanjali Medical College, Udaipur. Yeah, you can share your screen.
Am I audible, ma'am?
Yeah, Vishwa.
Yeah, you're audible.
Good morning, ma'am.
Make it full screen.
Yes, ma'am. Just a second. And now, is it full screen?
Not yet. It's okay. Go on, Vishwa.
Yes, ma'am. Yes, ma'am. Good morning, ma'am. I am Vishwa Mehta, a 3rd year medical student from GMC Udaipur. My patient is a 37-year-old female, homemaker by occupation, from based in Udaipur region. She came with chief complaints of a prolonged and heavy menstrual bleeding or vaginal since 4 months and lower abdominal pain since 4 months. History of presenting illness. Patient was apparently normal 4 months back when she had complaints of heavy and prolonged menstrual bleeding or vaginal during menstruation, lasting for 8 to 9 days in 30 days regular cycle, requiring 7 to 8 pads per day, associated with passage of clots and affecting her routine work. Patient also complained of pain in lower abdominal region for 4 months, incidence and onset gradually progressive, localized, dull aching in nature and non-radiating. Starts 3 to 5 days prior to menstruation and subside with onset of bleeding, with no aggravating factor and relieved by over-the-counter medications. There was no history of irregular cycle or intermenstrual bleeding. There was no palpable mass per abdomen. There was no history of mass coming out of vagina. There was no history of discharge per vagina. No history of fever, painful coitus, symptoms of bladder dysfunction or bowel dysfunction. No history of varicose vein, edema of limb, or unexplained weight loss. In the past history, there was no similar complaints in the past. No history of any chronic medical illness, diabetes, hypertension, asthma, epilepsy. No history of diagnosed thyroid-related problems. No history of blood transfusion, no other ongoing medications, and no noticed documented history of any drug allergy. Her Her menstrual history was age of attainment of menarche was 13 years. Past cycles were of 30 days with 4 to 5 days of flow, requiring 2 to 3 pads per day, not associated with any dysmenorrhea or passage of clots. The recent cycle was of 30 days with 8 to 9 days of flow, requiring 7 to 8 pads per day, associated with dysmenorrhea and passage of clots. Her marital history was 13 years. She had been married for 13 years of age, and her last menstrual periods was 6 November. Her parity index is 2 with 2 children, full-term normal delivery. First is male child, full-term normal delivery 12 years, and second is full-term normal delivery female children 8 years old. There was no history of any antenatal, natal, or postnatal complication, and patient does not plan to have conception in future. In contraceptive use, there was a history of use of male barrier method, and there was no history of tubal ligation. She consumes a vegetarian diet with normal appetite, adequate sleep, regular bowel and bladder habits, and there is no history of any addiction. There is no similar complaints in the family. Summary: a 37-year-old female with parity score P2L2 presented with heavy and prolonged menstrual bleeding per vaginal for 4 months, lasting for 8 to 9 days, mandating 7 to 8 pads per day. She also complains of lower pain in abdomen region, dull aching in nature for 4 months. From the history, it is suggestive of AUB. In general physical examination, patient was examined under adequate light with patient consent being taken. Patient is a middle-aged female, comfortable at rest, conscious, cooperative, well-oriented to time, place, and person, moderately built and moderately nourished. BMI was 30 kg per meter square. Pallor, there was mild pallor seen in the bilateral lower palpebral conjunctiva. No icterus, no cyanosis, clubbing, lymphadenopathy, or pedal edema. The vitals were all in normal range. In the abdominal examination was done under adequate light with proper exposure after explaining the procedure to the patient and with patient's consent in presence of a female attendant and after emptying the bladder. On inspection, the shape of abdomen was globular. All regions moved equally with respiration. Umbilicus was center and inverted. There was no fullness in flanks, no scars, dilated veins or sinuses. Hernial orifices were intact and there was no visible peristalsis. On palpation, I confirmed my all inspectory findings. There was no local rise of temperature, no tenderness. A firm transversely mobile mass with irregular surface was palpable at below the level of umbilicus in midline region, corresponding to 16 weeks of gravid uterus size. The upper border and 2 lateral borders of the mass were smooth and were well defined, and lower borders was not palpable with no fixity to skin or there was no tenderness on touch. There was no organomegaly in the abdomen region. On percussion, there was a dull note, no signs of fluid in abdomen. On auscultation, bowel sounds were heard, no bruise. Per vaginal examination was not done. Other systemic examination, cardiovascular system, normal heart rate and rhythm, S1 and S2 heart, respiratory normal vesicular gross sounds. CNS examination, no focal neurological deficits. Summary: a 37-year-old female with parity score P2L2 presented with heavy and prolonged menstrual bleeding per vaginal since 4 months and pain in abdominal region for 4 months. On examination, firm, non-tender, irregular transversely mobile midline mass of 16-week gravid uterus size with all borders palpable except the lower border and dull on percussion, suggestive of leiomyoma. Provisional diagnosis: a case of abnormal uterine bleeding, probably due to uterine fibroid, AUBL. Thank you so much, ma'am.
Okay, can you hear me now, Vishwa?
Yes, ma'am.
Okay, good presentation.
Thank you.
Very complete, well presented. Now, tell me, why do you think it is fibroid? What makes you think it's fibroid?
First of all, the age of patient, it is in the 30s to 40s range. So it is suggestive of fibroid. Secondly, ma'am, from the chief complaints, the patient presented with heavy menstrual bleeding and also the lower abdominal page, which is dull aching in nature, which is suggestive of congestive.
What is the symptomatology of fibroid?
Ma'am, generally patients are asymptomatic of fibroids and they present in the late stage. But if they present with symptoms, generally they present with heavy menstrual bleeding or pain in lower abdominal region.
Okay. Anything else?
They can even present with mass per abdomen in the later stages.
Yeah.
Yes, ma'am. Or if
when is it that women will present only with mass per abdomen without any symptom?
Yes, ma'am.
Why is it that some women present only with mass per abdomen?
Ma'am, it depends on the physique of the woman also. If the woman is obese, then it might be that she might not be able to feel the mass herself, or if she is thin and lean, she might be able to feel it.
Okay. So any other symptoms? What are you missing in the symptomatology of fibroid? See, most of them are asymptomatic as we told. More than 50% are asymptomatic.
Yes, ma'am.
If they are symptomatic, the most common symptom is going to be menstrual symptoms.
Yes,
then
ma'am.
they can have mass per abdomen. That's what
Yes,
you
ma'am.
told, right? Anything else you told about symptomatology?
Ma'am, they can present in complication phase also, like
Very rare. Leave the complications aside. Symptoms, presenting symptoms. A fibroid can present with so, and so. That's what I'm asking you.
yes, ma'am. I'm able to recollect now only 3 symptoms.
Can they have pressure symptoms?
Yes, ma'am. They can also have pressure
Pelvic
symptoms.
mass and pelvis has other important organs around over there. Okay, tell me what pressure symptoms they can have.
And they can have a frequency urination or acute retention of urine in case of a cervical fibroid.
Cervical fibroid or posterior lower corporeal fibroid also can lead to retention of urine. Okay, what else they can have? If it is an anterior lower corporeal fibroid, what symptom will they have?
Increased frequency of urination.
Yes, because they keep pressing on the fundus of the bladder, they'll have increased frequency of micturition. So there are so many pressure symptoms also. Don't forget. What else can be the pressure symptoms now?
Ma'am, they can even present with constipation or varicose vein or edema of limb.
If it is a posterior fibroid sitting in the sacral hollow, then they can have constipation also. Okay. What else they can have?
Ma'am, they can even present with varicose vein or edema of lower limb.
That is not very common. Okay. Very rare again. Other than that, any other pressure effect which is not symptomatic but can lead to significant damage? Ureters in a broad ligament fibroid. Ureters can get compressed, leading on to hydroerythronephrosis. Okay, so these are the pressure symptoms. What are other symptoms they can present with? Think in that line and tell me now. Other than bleeding, mass, abdomen, and pressure symptoms, there is one more symptom which is important nowadays. We do see a lot of women coming with that particular symptom in gynecology, and one of the causes of that symptom is known to be this: infertility. Okay. We usually diagnose fibroids in women when they're undergoing infertility evaluation also. So there are different ways. Why do you think women with fibroid have menorrhagia? What are the causes for heavy menstrual bleeding in fibroids?
Ma'am, this is probably due to increased vascularity of the fibroid structure. And secondly,
what is the most common and most plausible, obvious cause of heavy menstrual bleeding in fibroid? Which type of fibroid in a heavy menstrual bleeding?
Pardon, ma'am?
Which type of fibroid is associated with heavy menstrual bleeding?
Yes, ma'am. Submucosal.
Submucosal. So what is the explanation you can give for submucosal fibroid having more bleeding?
Ma'am, it's probably due to the high vascularity of the fibroid structure and
it is increased surface area of the endometrium. Right? Generally, the surface area of the endometrium is hardly 5 centimeters square, less than that. Okay. But when there is a big submucous fibroid, it will stretch the surface area and the bleeding area becomes more over. That's the most obvious thing. Other than that, what you're telling, the increased vascularity, then altered myometrial contractility. Some biochemical changes which occur over there. All these things will lead to increased incidence of bleeding in fibroid. One more important thing is I already mentioned in the last class, all these conditions are hyperestrogenic. Okay, yes. Fibroid itself is a hyperestrogenic condition. So there is an associated endometrial hyperplasia also among these women. Yes. Okay. So that is how the bleeding occurs. Like that, there are different causes for infertility in fibroid also. What are the different causes for infertility in fibroid? Can you think of any?
And they can be due to tubal blockage if the fibroid is around the tube or cornu of the uterus. They can be due to, if the fibroid is cervical region, they would inhibit the sperm penetration.
Sperm ascent. Okay. Not penetration, ascent. I can't hear you, Vishwa.
Hello.
Yeah, now you're audible. Go on.
Yes, ma'am. If they are in the uterine region, body of the uterus, they may have that they inhibit the implantation also.
Submucosal fibroids.
Submucosal fibroids. Yes, ma'am.
They can be a cause of infertility, subfertility. They can be a cause of abortions, anything. Okay. Yes. So fibroids can be symptomatic in different ways. Okay. Yes. So tell me, how do you say the mass what you're feeling in the abdomen in palpation is a uterine mass?
First of all, I considered the bladder being empty, so it is not a bladder mass. First of all, I examined the patient in empty bladder. Secondly, ma'am, the mass was.
You can't assume that because she's emptied the bladder, it is not bladder. Okay, if it feels like a cystic mass in the lower abdomen arising from pelvis, even though patient says she's voided, okay, we should make sure that we catheterize and rule out if it's a cystic mass. Okay, yes. Go on. Why it is not bladder? You have other plausible explanations here rather than telling she voided just now.
Yes, ma'am. Actually, I would like to do a per vaginal examination on bimanual.
No, in per abdomen, you tell me. You have some findings in per abdomen, right?
Yes, ma'am. Yes.
What are the pointers towards fibroid or uterine mass in per abdomen?
Ma'am, first of all, the mass was firm and it was asymmetrically enlarged and with irregular borders with in the midline region corresponding to the.
Most importantly, it's a midline firm mass arising from pelvis. Lower border was not palpable, right?
Yes, ma'am.
So it's something arising from pelvis. It is midline and it is firm to feel. And it was, what about the mobility of the mass?
It was transversely mobile from side to side.
Transversely mobile. Okay.
Yes.
So with these things, we are almost certain that it may be a uterine fibroid because it is bigger in size, 16 weeks. Now in bimanual, like you told you want to do a bimanual, right? Tell me in bimanual examination, how do you confirm that it is indeed a uterine mass?
The mass will move with a uterus and like with movement of uterus. Mass will with movement of uterus, it will move. Like
it's not like that. See, when you're doing a bimanual, your left hand is on the abdomen, your two fingers of the right hand is in the vagina. Okay, yes, what structure you will be feeling in the vagina when you put your fingers?
Firstly, the vaginal structure, anterior fornix and posterior fornix, then you
will feel cervix. That's the most prominent protrusion over there, right? So cervix. So how do you describe whatever you told is movements of the abdominal mass are transmitted to cervix? Okay, you move the abdominal mass. The transverse mobility is there, right? Okay, so move the mass. The same mass will get transferred across to the cervix. Okay, any other sign? I'll say that this is an ovarian mass. It's an ovarian fibroma if I tell you. How will you justify that no, it is a uterine mass in bimanual examination?
Ovarian mass would not move with uterine mobility, ma'am.
Yes, number one is that, then anything else. What is the groove sign?
Yes, ma'am. If we put our hand, we will able to feel a gap in case of a ovarian mass, but not in case of a uterine fibroid.
Yes, and uterine, the groove sign is absent. Okay, yes. So that is how we make out that this is a fibroid. So this one you told the diagnosis as AUBL. Yes, let's assume this patient was some 20-week size fibroid with only pressure symptoms.
Yes, ma'am.
Okay, what will be your diagnosis in that scenario?
Just pressure symptoms and 20 weeks of
fibroid.
Size. It could be fibroid as well.
It is a fibroid, but how will you put a diagnosis in that case?
I would like to go for ultrasound to confirm my diagnosis.
I'm telling you, clinical diagnosis, that's all. Here you told AUBL, right? I just want to tell you people that AUBL you will say for fibroid only when it's associated with abnormal uterine bleeding. If there is no abnormal uterine bleeding, then you will just put it across as fibroid. That's all. Okay, that's what I wanted to tell you. So how would you confirm your diagnosis?
We plan an ultrasound.
Ultrasonogram. Okay. So you've done an ultrasonogram and you find that it is indeed fibroid uterus. You see the origin, how many numbers. What's the age of patient's age?
Pardon, ma'am?
Age?
37 years, ma'am.
37 and she's finished her family?
Yes, ma'am.
Okay, but not sterilized, right?
No, ma'am.
Okay, so if the patient says, I don't want surgery, I'm still 37, what are the different options we have?
Ma'am, we have recent options like MRI guided high focused ultrasound, ma'am.
So first thing you will do is MRI guided high focused ultrasound. Huh? Don't go hype and down. No, first tell me what options we have. Her main symptom is menorrhagia, right?
Yes, ma'am. Yeah, so first symptom we can control bleeding, ma'am. We can have medical management and surgical management. In medical management,
doesn't want any surgery. Okay.
Yes.
She just wants some kind of symptomatic treatment. That's also. What symptomatic treatment can you offer to her?
Ma'am, we can offer medical management to control the bleeding and pain.
Tell what?
Yes, ma'am. Ma'am, estrogen we can offer, and ma'am, tranexamic acid.
Estrogen. What is estrogen now?
Ma'am, sorry. I meant to say that, ma'am, tranexamic acid, ulipristal, or mifepristone 486, IU 486.
First thing you'll offer is NSAIDs.
Yes,
okay, NSAIDs are the first line of treatment with or without tranexamic acid or antifibrinolytics. Okay, yes. That's what we're going to try first in any case of fibroid. Okay, with that it is not controlled. What's our next option?
We can go for then surgical management, ma'am.
No, medical. She doesn't want surgery. When a patient is against surgery.
Ma'am, then we can go for GnRH analogs, ma'am. Second line.
Analogs, how long can you give, Vishwa?
Ma'am, 3 to 4 months, ma'am, maximum.
So maximum 6 months. Okay, yes. 3 to 6 months is what it is. Okay. That's not enough for her, right? She doesn't want surgery at all. What are we going to achieve by giving a treatment which is going to cause a lot of side effects? It will lead to a pseudo-menopause kind of picture. Okay. So we can't give analogs for very long. Analogs are used for very specific conditions like woman is about to attain menopause, or you're planning a myomectomy in an infertile lady, you want to decrease the size of the fibroid. That is where we use analogs. What is available nowadays, which is going to control the bleeding very efficiently and which will add for years.
Uterine artery embolization, ma'am.
You're not getting the question at all. Some kind of intrauterine system.
Okay, ma'am, LNG-IUS.
Why LNG-IUS is not coming? For any AUB, the real Rambana nowadays is LNG-IUS, whether it is adenomyosis, anovulatory DUB, or it is fibroid-associated thing. If only problem, when can you not use Mirena in case of fibroid, which is causing AUB?
Ma'am, in case of a large fibroid or acute bleeding, ma'am.
In case of cavity distortion. Okay. If the fibroids are submucous and distorting the cavity, how will you place a Mirena there? It may get expelled or it may not really. It will be technically difficult to put in a Mirena only. Other than that, Mirena is a fantastic drug for or way of delivering the drug for fibroids. Okay. I think we have done with the time. I want the organizers to remind me of the time, please.
Yeah, ma'am. Still 3 minutes left, ma'am.
3 minutes left. Okay. Fine. So now let's assume this patient was 12-week size fibroid. Okay, what else will you think of other than fibroid? Uterus is 12-week size. Okay, same symptoms, menorrhagia and dysmenorrhea. What other condition will you think of?
Ma'am, it can even be adenomyosis.
How do you distinguish adenomyosis and fibroid by history and examination?
Ma'am, first of all, there would be intracyclical bleeding in adenomyosis.
What? I didn't get it.
Ma'am, intercyclical bleeding or
intermenstrual bleeding.
Intermenstrual bleeding, ma'am.
Okay. That's all.
And ma'am, secondly, there would be like ma'am, from the history or examination part, ma'am,
whichever way you want to go. Generally, we prefer history first and then go for examination, right?
Ma'am, the age
what is the symptomatology of adenomyosis?
Ma'am, patient would be more than 40 years of age, first of all.
Multiparous, more than 40. But in fibroid, it is 30 to 40 nulliparous. Common. Yes, so that you distinguish and tell me. Now you know the answer, you're not able to put it across, that's all.
Yes, ma'am. And ma'am, secondly, the chief complaints would be
Chief complaint would be?
Ma'am, in fibroid case, it would be heavy menstrual bleeding with the lower...
Adenomyosis?
Ma'am, adenomyosis, the patient will complain of intermenstrual bleeding.
No, you are completely, mistaken over here. Intermenstrual bleeding is not a symptom of adenomyosis at all. Why are you thinking of, here, what is the problem in adenomyosis?
Ma'am, in adenomyosis, endometrial glands grow in the myometrium region.
So how will that lead to intermenstrual bleeding? Why should that lead to intermenstrual bleeding? The bleeding is occurring in a confined space over there during menstruation, that's all. That causes all the symptoms of adenomyosis. Okay, adenomyosis is an entirely different thing other than what you have in the mind actually. Okay, adenomyosis symptomatology is entirely different. I think we'll leave it here. Okay, leave that. What surgery, if the patient is for surgery, what do you want to do for this patient, your patient?
Ma'am, myomectomy.
You want to do myomectomy. What is the problem with myomectomy? She's finished her family. She does not want to have any more children. She will tell you, see, do some surgery where I don't need any further treatment for this particular thing.
And then we can go for total abdominal hysterectomy. And if she doesn't want any further construction, ma'am, then we can go
any other way of doing other than total abdominal hysterectomy?
Ma'am, vaginal hysterectomy we can do.
Yes, vaginal hysterectomy in 16-week size fibroid also. Okay, natural orifice vaginal hysterectomy can be done. Other than that, any other way of doing hysterectomy?
Ma'am, laparoscopic hysterectomy.
Am I audible?
Yes, ma'am.
Yes, ma'am. Ma'am? Yeah, it's time up, ma'am.
Yeah, we can do a laparoscopic or a robotic or whatever. Minimally invasive surgery also can be used.
Yes,
okay. Now, Vishwa, I can't see you.
Ma'am, I am.
What happened?
Hello.
Is my internet a problem or yours?
Hello.
Excuse me, ma'am. Sorry to interrupt. Ma'am, it's time up, ma'am.
Time up, right? Okay. Okay, Vishwa, done. Thank you.
Thank you, sir.
Good.
Yeah.
Thank
Good,
you.
Vishwa.
Thank you.
Our next participant is Ms.Preethi. She is 4th year MBBS student from Coimbatore Medical College.
Okay. Start, Preeti. Share your screen and start. Coimbatore Medical College. Okay. Start.
Is my screen visible, ma'am?
Yeah, it's visible. It's fine. Start.
Okay. 1 minute, ma'am.
Any issue?
Yes, ma'am. The screen is not changing. Yes. Mrs. Tilakamalar, a 47-year-old female with a parity index of para to live 2, owns a tea shop hailing from Mettapalayam belonging to upper lower socioeconomic status, whose last menstrual period is 7th of November and last childbirth is 23 years back, presented to CMCH with the chief complaints of mass descending per vaginum for the past 2 years. Patient was apparently normal before 2 years, and then she noticed a mass descending per vaginum, which was insidious in onset, initially small in size and gradually increased to attain the present size. It is associated with lower backache, which is on and off type of dull aching pain, which increases towards the end of the day for the past 5 months. And the mass is aggravated on coughing, straining, standing, and lifting weight, and it is reducible manually and on lying down. So the patient has no mass while waking up from sleep, and it increases as the day passes. And is associated with white discharge, which is scanty and not itching and not foul swelling for past 3 months. Is not associated with any bleeding. History of difficulty in walking and carrying weight present, and history of difficulty in initiating urination, which the patient overcomes by pushing the mass inside, and there is history of incomplete voiding of urine. There is history of dribbling of urine while laughing, coughing, and incomplete passage of stools. There is history of lifting heavy weights and chronic cough, and no history of fever, burning micturition, loss of appetite, weight, and no history of smoking, diabetes mellitus, steroid therapy. Menstrual history, she attained menarche at 16 years of age, and she has irregular cycles for every 30 days with 3 days of moderate flow and is not associated with clots pain, and her last menstrual period is 7th of November. She is married at 21 years of age, which is non-consanguineous marriage, and obstetric history. Her parity index is para to live 2. Her first pregnancy was at 22 years of age, which is a full-term normal vaginal delivery conducted at home by her mother, and she delivered a male baby weighing 3 kg at birth. Episiotomy was not given, and no history of perineal tear. She resumed her day-to-day activities by day 4, and she did not have any home help. And there is no history of contraceptive usage after that. With the interpregnancy interval of 2 years, her second pregnancy was at 24 years, and it was full-term normal vaginal delivery conducted at home by her mother again, and delivered an alive, healthy female baby weighing 3.2 kg at birth. Episiotomy was not given, and there is history of perineal tear for which she sought treatment. She resumed her day-to-day activities by day 5, and there is no history of pelvic floor exercise antenatally and postnatally. Tubectomy was done 6 months after her last childbirth. Past history, she is on antiretroviral therapy for the past 10 years, and she has history of pulmonary tuberculosis for which she took treatment. It's 2014. There is no history of diabetes mellitus, hypertension, COPD, and myopathy, and no history of blood transfusion. Her personal history is normal, except that for disturbed sleep, bowel, and bladder habits. Family history, there is no history of prolapse seen in her family. General examination was normal with a BMI of 21 kg per square meter, and she is clinically, there was no pallor and there is no lymphadenopathy. Thyroid, breast, and spine examination were normal. Vital and other system examination were clinically normal. Examination of abdomen. The patient with comfortably full bladder, supine stress test was first done and is found to be positive, and then she was asked to void the urine and lie in dorsal position with the knees and hips semi-flexed and adequately exposed. On inspection, the abdomen was scaphoid shape, umbilicus in the midline, and all quadrants move equally with respiration. Tubectomy scar, just 2 centimeter transverse scar below 5 centimeter below umbilicus is seen, and stria albicans seen, and no sinuses, dilated veins are seen, and hernial orifices are normal, so are free, and palpation, percussion, and auscultation are clinically normal. Examination of external genitalia. On inspection, pubic hair and labia majora appears normal. There is widened vaginal intritus, a pinkish globular mass lying just outside the intritus is seen. There is hyperpigmentation, and there is no ulcer seen. Mucosa appears congested, and rugosity is present. The external anal sphincter appears normal. On palpation, the mass is reducible and not able to get above the fundus. The levator ani muscle tone is reduced. On speculum examination, it was done after reducing the mass. On depressing the posterior posterior vaginal wall with sim speculum, a bulge is seen in the upper 2/3 of the anterior wall, and a protrusion is seen after retracting the speculum from the mid-third of the posterior vaginal wall. Summary. Mrs. Tilagamallar, a 46-year-old female belonging to lower socioeconomic status, presented with mass descending per vaginum with difficulty in micturition and defecation, with a past history of tuberculosis, lifting heavy weights, and home delivery. Examination revealed a pink globular mass lying just outside the introitus, which is reducible, not able to get above the fundus, with no ulcers. Probably a case of uterovaginal prolapse grade 3 with rectocele and cystocele.
Okay, the presentation. What I want to know is, what is a pink globular mass? Why do you describe it as pink globular mass?
Because of its shape and the external os was seen like that, ma'am.
External os is seen, right?
Yes, ma'am, it was seen, ma'am.
Os is seen. Why don't you just say cervix is lying so many centimeters from the introitus? Very simple.
Okay,
it
ma'am.
Present as pink globular mass. Moment you say pink globular mass, I will think of some cyst coming out. Okay, there is no os at all, or a fibroid polyp coming out. Okay, so if you have the os, you should present it as cervix is seen lying around 6 centimeters from the introitus.
Okay, ma'am.
Then comment about, is there any globular swelling on the anterior wall which is suggestive of cystocele.
Okay, ma'am.
Cystocele examination in a 3rd degree prolapse is not a perspeculum finding. Only the posterior wall relaxations like enterocele and rectocele we will comment in perspeculum. Okay. Next to that, when the patient is doing the inspection of genitalia, you ask the patient to strain fully. At that time, you'll be able to appreciate cystocele very easily. Right? Only in case where it is less than 2nd degree prolapse, you need a speculum to demonstrate all these things. Otherwise, you don't need a speculum for cystocele, but you need a speculum for other 2 things.
Okay, ma'am.
So in this patient, you think it is genital prolapse?
Yes, ma'am.
Okay?
Yes, ma'am.
What are the factors which will tell you that it is indeed a genital prolapse?
It is the first thing is the cervical os was seen, which
start from history, ma'am.
Okay, ma'am. With the history, she has a positive history of pulmonary tuberculosis, and she used to weight a heavy lips, and there was mismanaged, like home delivery was done, and it was mass descending per vaginum, with the mass increasing towards the end of the day. And there is also a history of difficulty in initiating micturition and incomplete voiding of stools, which suggests
which component of your prolapse is leading to these symptoms?
Ma'am?
Which component of your genital prolapse is leading to this symptom?
Anterior compartment prolapse leads to this incomplete, difficulty in initiating the urine, and the posterior compartment is the incomplete voiding of stools, ma'am. She's 47-year-old female, ma'am.
Not postmenopausal.
No, ma'am, no.
You know that generally prolapse is a phenomena which occurs in postmenopausal women.
Yes, ma'am. Yes, ma'am.
Injury caused, basic cause is obstetric injury, and it gets augmented because of estrogen deficiency.
Yes, ma'am.
Tell me what led to prolapse in your patient, that she became, manifested prolapse before even attaining menopause?
With a history of she does heavy labors at home, ma'am, and there is also home delivery, and she has a history of perineal tear, which was repaired late after the delivery, ma'am, and there is also a history of pulmonary tuberculosis.
Probably. So, what do you call those different factors which will lead to prolapse before even menopause? It's called as precipitating factors. Okay. Tell some precipitating factors. You actually told, you just have to enumerate them now.
Yes. Chronic increase in intra-abdominal pressure, obesity, smoking, and any connective tissue disorders. Asthenia.
That's a basic factor like congenital prolapse. Okay. To leave that. For basically precipitating factors, the predisposing factor is your obstetric injury. Okay. But somehow estrogen manages to keep it inside till menopause, and then after menopause it will come out. Okay. So obstetric injury is a must for any kind of genital prolapse. It's not congenital. Okay. You have a previous to LSAS patient, you'll never see prolapse in them, right? Okay. So here the precipitating factors are basically conditions where there is increased intra-abdominal pressure, as you told, like chronic cough, chronic constipation, lifting heavy weights, intra-abdominal tumors, ascites. All these things will increase the intra-abdominal pressure, so the prolapse gets manifested before even menopause. That's what has happened in your lady.
Yes, ma'am.
Now let's assume we are telling it's 3rd degree, right?
Yes, ma'am.
Okay. If the cervix is lying 8 centimeters outside the introitus, but it is not procedentia, what finding to expect in bimanual examination?
Bimanual examination, I won't be able to get above the fundus, ma'am, in case of
That is
grade.
not bimanual, that is external examination. Fully spent. You reduce the prolapse, you do a bimanual. What finding will you get? See, when I say cervix is 8 centimeters outside the introitus, okay, we assume that it may be procedentia, right? But it is not procedentia. The uterus is still inside the vagina. It does not come outside the introitus. So what finding can we anticipate there?
It's like elongation of the cervix, ma'am, vaginal portion of the cervix.
Not vaginal portion.
Supravaginal portion.
Supravaginal elongation of cervix, because the level 1 delancey, that is your uterosacrals and mecanthroids are strong. Whatever prolapses come out is because of level 2 deficiencies. The vaginal cystocele, rectocele, that is pulling the cervix down. So the portion of cervix above the level of vagina actually gets elongated. Okay.
Yes.
That means that the level 1 is strong. We can use the same things for anchoring the vault. If it is procedentia, okay, it is lying some 10 centimeter outside the introitus. Okay.
Okay.
And the nicely fundus pinch sign is positive, or we can get above the fundus and all this stuff. You know, it is procedentia. What treatment will you give to the patient?
We can do vaginal hysterectomy, ma'am. Vaginal hysterectomy can be done, ma'am. With the ma'am.
That's enough. Vaginal hysterectomy is enough.
No, ma'am. With the pelvic floor repair has to be done. Anterior colporrhaphy with posterior colpoperineorrhaphy has to be done, ma'am.
Okay, so you will do a cystocele repair and all this stuff. But I told you it is procedentia. A huge procedentia, 10 centimeter outside. Okay.
Yes,
so how do you prevent a vault prolapse in this patient? In any case of prolapse, when you're doing vaginal hysterectomy with colporrhaphy, how do you prevent occurrence of vault prolapse in future?
We have to first we should make sure that there is no introcele. If there is, we should do mechial cholecystoplasty, ma'am. And then we can do uterosacral suspension, ma'am.
Okay, so I told you in procedentia, your uterosacral is not going to be good. Remember that. That is why it has become procedentia. Okay, the native supports are not going to help. So we have to do some other ancillary procedure. What do we do?
We can do sacrospinous suspension.
Very good. Sacrospinous colposuspension is what we do in these cases, where we know that this patient general health is very poor. She cannot avoid any of these precipitating factors post surgery also. If we do not anchor the vault to some fixed structure using some other procedure, they'll come back with vault prolapse again. Okay, so it's important that you take care of that. Okay.
Okay.
You have seen any case of prolapse being done?
No, ma'am.
You also not seen. Okay,
No.
fine. And all these COVID kids are basically nothing, no OT, nothing. Fine. So in case, if you have a TAH, 16 week size, you're doing a laparoscopic or an abdominal hysterectomy, and they're doing a procedentia of odd Mayo surgery, that same vaginal hysterectomy with PFR, what will be the gross difference between these two?
Ma'am, I didn't get the question, ma'am.
See, there are two tables in your OT. Okay, one OT, one TAH is going on, other OT, one odd Mayo is going on. The same prolapse surgery. How do you, what is the gross difference between these two cases?
First thing, the approach will be different, ma'am, and the positioning of the patient is different, and the clamp.
Complications.
Ma'am, complication in abdominal laparoscopic abdominal surgery, there is increased chance of damage to the ureter, ma'am.
No. Why should we damage ureter in abdominal surgeries? Unlikely. See, what the gross striking difference is going to be the amount of bleeding.
No.
In lap surgeries, in abdominal hysterectomies, we hardly lose any blood because we clamp and cut. Everything is clamped and cut. Everything is clamped and there is no dissection involved. But in case of odd Mayos, there is a lot of dissection needed to raise the vaginal flaps and all this stuff. The bleeding is going to be significant. Okay. So this primary hemorrhage is one of the complications. What are the other complications of odd Mayo surgery?
The intraoperatively there could be anesthesia complication, and then injury to bladder, ureter can and rectum can happen. Postoperatively, reactive hemorrhage can happen, ma'am. And like late complication, there could be vault prolapse.
Okay, can we have fistulas, late complication?
Vesicovaginal fistula can happen.
Vesicovaginal fistulas can also occur if you are not being careful during the surgery. Okay, these are different complications. Now, in a younger patient, what surgery will you perform?
In a younger patient, if she's nulliparous, we can do sling surgeries, ma'am.
Sling surgeries, what do we use in sling surgeries?
We use Mercelin tape, ma'am. And the common, there can be two approaches, anterior and posterior. Anterior is like a dynamic approach where we anchor it to the rectal sheath.
The dynamic procedure?
Purendare
See, remember, most of the sling surgeries are devised by Indians. So we should surely know these names. Okay. Purandarese is the dynamic sling where anterior approach is used to fix the supports to the rectus sheath.
Okay.
So whenever patient contracts, abdomen contracts, it will automatically pull the uterus up. Okay, it's a dynamic sling. What's the posterior sling?
Posterior Shridocus and Kanna sling operation is done.
Shridocus is posterior. Kannas is lateral.
Okay.
Like round ligament. Okay.
Okay.
The Shridocus is recreating the uterosacral ligaments.
Okay.
These are the different sling surgeries we use. Any other way of doing sling surgeries other than these, what you mentioned? Laparoscopically, nowadays everybody wants minimally invasive surgery. So we do cervicopexy. We fix a muscle tape to cervix and take it retroperitoneally and fix it to the sacral promontory.
Okay.
Pull the cervix up. Okay, there are the sling surgeries. Sling surgeries, very important to remember that we'll have only uterine descent. We won't have vaginal relaxation over there. The girls are not delivered, they're nulliparous girls. Okay.
Yes.
So it's only the uterus which needs to be pulled up and fixed somewhere. That's all.
Okay.
That's how this functions. Okay.
Yes.
In a slightly older lady, like 25-30 years of lady, what's the option for us?
If she wants to conceive again, we can ask her to finish the family as soon as possible, and we can do Fothergill's operation, ma'am. Or else we can go for Shridocus modification of Manchester operation with the cervical amputation.
Modification of Manchester surgery.
It's the same as that of the Fothergill's, except that the cervical amputation is not done, ma'am.
So if the patient is having elongation of cervix, you will go for Manchester or Fothergill's. If there is no elongation of cervix, then you will go for Shridocus modification of Manchester. Good.
Yes.
And another important essential difference is in Manchester, we use Macken rods to support the neocervix. In Shridocus modification, we open the pollicis and take the uterosacrals and get them anterior to support the neocervix.
Okay.
So that's the most important difference between these two conditions. Okay. What complications a woman can have if she goes on to become pregnant after Fothergill surgery?
There is increased chance of cervical incompetence, ma'am, and there can be
insufficiency. The term is no more incompetence; it is cervical insufficiency.
Okay.
Then,
and there can be adhesion formation also, ma'am.
What's adhesion formation?
Cervical adhesions, like if any
fibrosis and leading to cervical stenosis. So they might not undergo cervical dilatation at all. It can be either way. Either they become cervical insufficiency and have a second trimester abortions, or if they go on to term, they can develop cervical stenosis. Dystocia. Cervical dystocia can happen because of fibrosis in the cervix. Okay, the dilatation may not occur effectively as it occurs in a non-scarred cervix. Okay.
Okay.
Good. This is Preethi, right?
Yes, ma'am.
Okay. Good. Done.
Thank you, ma'am.
Okay. We have our next presenter, Ms. Padmavathy. She is third year MBBS student from Adi Chunchanagiri Institute of Medical Sciences, Belur.
Okay, Padma, go
on. Good morning, ma'am.
Morning.
Yes.
Is my screen visible?
Yeah. Go to the full screen, please.
Yes, ma'am. Is it okay?
Yeah, fine.
Okay. So I will start my case presentation. Here's a patient named Mrs. X, who's 55 years old, who's a housewife from Bidiganavile in Nagamangla Taluk, who belongs to the lower socio-economic status, lower middle class. She presents with chief complaints of mass per vaginum since 5 years. She noticed this 5 years ago, which was the mass was initially of small in size and has gradually increased to the present size. It bulges out on lifting heavy weights and decreases when the bulge is pushed manually. It is not associated with back or pain abdomen. She gives history of doing strenuous work like lifting heavy weight and standing for long periods of time. She has no history of difficulty in micturition, increased frequency of urination, burning micturition, involuntary voiding of urine, incomplete emptying of urine, manual reduction for emptying bladder. No history of mass per abdomen, no history of bowel disturbances, no history of discharge per vaginum or white discharge per vaginum, no history of dyspareunia, no history of chronic cough, weight loss or loss of appetite. Her menstrual history is she attained age of menarche at 15 years and she attained her menopause 4 years back. Her previous cycles were found to be regular and without passage of clots or dysmenorrhea. Her obstetric history is her married life is for She has a married life of 30 years, which is non-consanguineous marriage. Her obstetric score is para 2, living 2. Spacing of birth between the two children is 4 years. And she resumed work after 3 to 4 months after each delivery. Both the pregnancies were normal vaginal deliveries happening at Bangalore Government Hospital. The children are alive and healthy now, and she had no intrapartum or postpartum complications. She underwent a tubectomy at Nagamangala Government Hospital 6 months after her last child, her second child's birth. She has her past history is there's nothing significant. Family history, nothing significant. Personal history, her diet is mixed, appetite is good, sleep is undisturbed, bowel and bladder functions are regular and normal. She has no other health affecting habits like smoking or consumption of alcohol. Summary at the end of history, Mrs. X, age 45 years with obstetric score para 2, living 2, is a postmenopausal lady belonging to lower middle class status. She has previous history of vaginal delivery and came with complaints of mass per vaginum to undergo further evaluation. General physical examination. She's a middle-aged lady, moderately built and nourished, conscious, cooperative, alert, well-oriented to time, place, and person. On examination, she has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Her vital signs are clinically normal, and her spine, thyroid, and breast findings are also normal. Systemic examination, CVS, RS, and CNS findings are all normal. Per abdomen examination on inspection, abdomen is normal shape and contour. All quadrants move equally with respiration. Umbilicus is central in position. Sterilization scar is seen. No sinuses, dilated veins or scars. Other scars, no visible pulsations of peristalsis. All herniated orifices appear intact. Palpation, no tenderness, no local rise in temperature, soft, no organomegaly. Tone of the abdominal wall muscles is normal. Percussion, tympanic note heard, liver dullness is heard at fifth intercostal space. Auscultation, normal bowel sounds heard. Sorry. On local examination, external genitalia, pubic hair sparse, labia majora and minora are atrophied, gaping of introitus present, perineal body is thinned out, external urethral meatus is normal, stress urinary incontinence is not elicited, bulbocavernous and anal reflexes are intact, external anal sphincter tone normal. Per vaginal examination or the per speculum examination shows mass protruding out of introitus, which appears to bulge on straining. Rugosity seen on vaginal wall, lateral sulci is normal. Uterovaginal descent of 3rd degree noted. This leading part of cervix is seen. Cough impulse negative. No decubitus also present. No ulceration or bleeding present. Scars of vaginal infection absent. No signs of hyperpigmentation seen. On palpation, the mass was measured and it was found to be 8 to 4 centimeter size. You cannot get above the protruding mass. There is no adnexal mass or tenderness and no bleeding on touch associated. On bimanual examination, the uterus is found to be retroverted, atrophic, and bilateral fornices appear to be free. Per rectal examination, the findings are normal. Levator ani tone is of grade 4 type. At the end of history and examination, Mrs. X, age 55 years, a postmenopausal lady, multiparous, came with complaints of mass per vaginum since 5 years, aggravating on physical exertion and relieved by manual manipulation. On examination, a reducible mass is present, extending outside the introitus, and we are unable to get above the mass. Hence, the probable diagnosis of this patient is 3rd degree uterine prolapse with uterovaginal descent. Thank you.
Good presentation, Padma.
Thank you, ma'am.
Go back to your history slide. What are the symptoms, presenting symptoms of this patient, other than mass descending per vaginum? What are the symptoms she has? No other symptoms?
Ma'am, she gives no history, no other significant history
What
of
symptoms do you expect in a case of genital prolapse?
Ma'am, usually you would expect maybe dyspareunia, or you would expect
the patient
discharge.
Is sexually
active? Ma'am, we did not note that.
You should always ask, especially in a lady who is perimenopausal. It's very important to ask, because sometimes what happens in prolapse surgery, overzealously will remove a lot of vagina and it will become very difficult for them to have any kind of intercourse. Okay, so if she's sexually active, we have to make sure that we maintain the length of vagina. Okay, that history should be elicited. When you tell the marital history, in that you please add a sentence: patient is cohabiting with her husband.
Okay.
Yes, ma'am. Other than that, what symptoms do you anticipate? If there is a nice big prolapse with all components like cystocele, rectocele, everything, what symptoms do you expect in the patient?
Ma'am, you will expect a backache.
Backache, okay.
Or a dragging pain in the pelvis. Ma'am, you can also expect discharge.
Okay. Why will they have discharge in prolapse? What's the cause of discharge in vaginal discharge in prolapse? They do have this discharge. Please remember, they'll always have a wetness of the underclothes because of prolapse lying outside. Why do they have discharge?
Ma'am, because there's protrusion of ma'am, is it because it protrudes through the introitus, so the discharge spills out and there's
one main thing in prolapse is there's a lot of congestion, right?
Okay.
Because
Yes, ma'am.
when the uterus comes down, there's going to be a kinking occurring at the level of uterine and the ureter crossing.
Okay.
So whenever there is kinking of the uterine vessels, the vascular bundle, what happens is the veins will get compressed because they are thin walled. But the arteries will keep pumping the blood anyway because they are thick walled, they won't get obstructed very easily. But the veins being thin walled will get completely obstructed. That is why there is a lot of venous congestion in prolapse, which is a cause of many of these things. The same venous condition will lead to increased discharge also.
Yes, ma'am.
But what discharge we have in prolapse is generally just watery discharge, which is actually transmission of fluid across the vaginal epithelium. Vagina by itself does not have any submucosa or any glands in the vagina. Please remember. If there is any kind of wetness on the vaginal surface, it means it is just transmission of fluid because of vascular congestion. That's all. Okay, then they can have serous discharge if they have a decubitus ulcer.
Yes.
Right? Which can be associated with some sort of blood streaking also, depending on if there is any trauma to decubitus ulcer. Decubitus ulcer itself is a tropic ulcer. Okay, because of venous congestion. But it can get traumatized because it's lying outside.
Yes, ma'am.
So that is one thing. And then they can also have increased mucoid discharge because of the congestion of endocervical area. Endocervix has a lot of glands. So they can have mucoid discharge because of that. But the most common among all the three is the watery discharge, which is due to transudation across the vaginal epithelium. That's the causes of discharge per vaginum in prolapse. Please remember. Okay.
Okay.
You can also have postmenopausal bleeding because of your decubitus ulcer. Okay. What are symptoms they can? What about the urinary symptoms in prolapse?
Yes, ma'am. You can have stress incontinence, or you can have difficulty.
Is that the most common symptom?
No, ma'am.
It's the most common urinary symptom.
Ma'am, increased frequency?
Increased frequency can be there, but generally most common urinary symptom is going to be difficulty in initiation of micturition. Okay, which is relieved on splinting. They just reduce the mass, then they'll be able to void. Okay.
Yes.
Why is there increased frequency or burning micturition, whatever written over here? No. Why do you have all these symptoms?
Ma'am, because in a prolapse, there's also in case if it's a prolapse in the prolapse of the anterior vaginal wall, there is a pressure applied on the bladder. It causes cystocele.
Yeah, the cystocele is there. That is why they have urinary symptoms. But what causes all these symptoms? Increased frequency, dysuria, burning, micturition.
Ma'am, burning micturition.
Okay.
Ma'am?
Why is, see, all these symptoms look like cystitis to me. Is there an increased incidence of cystitis in prolapse?
Yes, ma'am, there is.
Why is there an increased incidence of cystitis?
Ma'am, because I think it's because there's difficulty in micturition, so the urine, the person cannot void out of the bladder, and as a result it accumulates.
What happens is, patient will never be able to void completely in prolapse. Part of the urine is always left behind in the bladder because the bladder is outside. Okay, so they won't be able to empty the bladder completely. There's going to be some amount of incomplete voiding, okay, which leads to stagnation of urine in the bladder. And a stagnated urine is a good culture medium.
Yes.
So the bacteria will be able to grow easily in it. If there is something which is flowing always, like in case of vesicovaginal fistula, we'll never see infection because urine never stagnates there. It keeps coming. Okay. But in case of prolapse, because there is stagnation of urine, urinary infection is very common. Okay. That's why we have all these symptoms. What causes stress urinary incontinence? You mentioned in your examination there is no stress incontinence. Okay. Is it common in women with prolapse when compared to women without prolapse?
Yes, ma'am.
Yes. Okay. So what causes stress incontinence in prolapse?
Ma'am, again, is it the similar reason because of the anatomy? There's no proper support. So
stress incontinence is basically because of hypermobility and descent of the bladder neck.
Okay.
Okay.
Yes.
The bladder neck, which is supposed to be above the level of genital diaphragm, pelvic diaphragm, comes below the level of pelvic diaphragm.
Okay.
So whenever there is increased intra-abdominal pressure, it will only act on the bladder and not on the bladder neck. That is why they have stress incontinence, where they have escape of urine whenever there is increased intra-abdominal pressure. Okay.
Okay. Yes.
Okay, Padma. Now tell me,
Yes,
how will you investigate your patient?
Yes, ma'am. Yes, ma'am. Ma'am, we can investigate. I'm so sorry. Ma'am, I'll just not put it on full screen.
Just stop sharing your screen and just talk.
Okay, ma'am. Ma'am, investigation, you can do.
What happened, man? Am I audible? Organizers?
Yes, ma'am, you are audible.
Okay, tell.
Yes, ma'am.
I didn't hear anything what Padma told. Please repeat your answer again.
Yes, ma'am. You can do routine blood and urine culture. You can do urine culture. You can do routine blood tests like complete blood count and random blood sugar investigation. And you can also do pre-op evaluations like USG.
What do you want to look for in USG? Why do you need ultrasonogram in prolapse? Is prolapse a clinical diagnosis or it is an imaging diagnosis?
Ma'am, clinical.
Then why do you want ultrasound? What exactly do you have in your mind when you told ultrasound?
Ma'am,
can you confirm cystocele by ultrasound? No, right?
No, ma'am.
So
no,
what
ma'am.
do you want to look at in ultrasound?
Bladders, something in the bladder.
Urine culture is the one exam we do for any cystitis.
So okay.
Ultrasound is not going to help you for bladder.
Okay.
You want to tell ultrasound, you should know how to justify ultrasound. Okay.
Yes.
You want to look for any, excel masses or clinical examination reveals any kind of abnormality, only then you use ultrasound. If clinical examination is normal, the way you have presented, there is no role of ultrasound, especially in the 3rd degree prolapse. But if the same case was precedentia, long-standing precedentia, I would do an ultrasonogram. For what will I do an ultrasonogram? A long-standing precedentia, I might do an ultrasound also. For what I would do an ultrasound in that scenario?
Well, vaginal eversion to try.
How do you diagnose vaginal eversion by ultrasound?
Ma'am, I don't know.
We want to look for basically hydronephrosis if there is ureteral kinking. I told you there's going to be kinking at the level of uterine arteries and ureter. So in precedentia, it can affect even the ureter over there. So ureter gets bleeding on to hydronephrosis. So to look for that, we can do an ultrasound in case of long-standing precedentia. I'm just telling you how can you justify that stupid thing you told of ultrasound. Ultrasound don't ever comment until and unless you have some issue like there is postmenopausal bleeding, you want to look at the ET, or adnexal feels there is some fullness, you want to look for any adnexal mass. Okay, otherwise, don't say ultrasound in prolapse. Prolapse is clinical diagnosis. Okay, you have done your investigations. She's found to be fit for surgery. Okay.
Yes, ma'am.
But the patient says, I don't want the surgery right now. I'll come after some time. What are the treatment options she has?
Ma'am, is pessary.
Pessaries, yeah.
And
what do you use commonly?
A ring pessary, ma'am.
A ring pessary, okay.
Ma'am, and she's also postmenopausal. So if we are recommending a ring pessary, we should also give topical estrogen.
Okay, you want to give, okay.
Yes, ma'am.
Then? Anything else? How long you can keep the pessary there? She comes, you put in a pessary today. How long she will keep the pessary inside?
Ma'am, 3 months.
3 months, okay. She'll come back, okay, after 3 months and get it replaced. And she can't keep it inside for more than 3 months. Good. Okay, fine. What else in your prolapse case? This is the 3rd prolapse today.
Yes, ma'am.
See, undergraduate level prolapse, basically they'll ask you the obstetric history. Yeah, tell me your obstetric history. We still have 4 minutes left, so let's discuss the obstetric history. I'm going back, I'm sorry, but...
No, ma'am, it's okay. Ma'am, okay, so she has a married life.
Get to any contributing factor for prolapse in your obstetric history?
Ma'am, should she, maybe she resumed work
3 to 4 months after delivery is luxury. Okay, you saw the previous case, 5 days after delivery.
5 days, yes, ma'am.
In your case, I don't really see a lot of problems in delivery, right?
Yes, ma'am. During delivery,
babies, good interpregnancy interval. What else? You keep on counting the way I'm counting.
Ma'am, spacing of birth is also adequate.
Good. Okay. Number of children also is not too many, not paraphylitic.
Yes, ma'am.
The other case had. So everything is ideal.
And
tubectomy also is done.
Hello.
Also fine. Yeah. Not audible?
Hello. Hello, ma'am. Am I audible?
Yeah, you're audible. Am I
yes,
audible?
Yeah. Yes, ma'am. Yes, ma'am.
Tell me, is there anything in this history suggesting that she had significant obstetric trauma?
Ma'am, no, because even the tubectomy done is a minimally invasive procedure. So
that's okay. Even if you do a mini laparotomy, it won't lead to prolapse.
Yes, ma'am.
Go to the next slide. What's your next slide? That's your obstetric
past history. Obstetric history is only so much.
Okay. So what do you think led to prolapse in this lady?
Ma'am, she gives history of doing a lot of strenuous work. And she stands for a long period of time in the day. So maybe it's because of the physical exertion.
Physical exertion. One thing is, in our side of the country, in South India especially, in women belonging to lower socioeconomic status, we see that their nutrition is always affected. Their nutrition is not good. What happens in a family when there is limited amount of food available, the first person to get food will be the breadwinner of the family.
Yes.
Okay, then the kids, the small kids, then the elderly. The last person who will get food is the mother or the lady of the home. Okay, so they're almost always they'll have malnutrition. Okay,
yes,
so prevailing general poor health of this woman, the general health, not the medical kind of thing, will also contribute to development of prolapse. Okay, and all these things will get augmented when they attain menopause.
Yes, ma'am.
Estrogen also will stop protecting them and they'll develop these particular problems. Otherwise, her obstetric history looks ideal to me. There is no reason why she will have any kind of prolapse. Okay.
Yes,
and in your patient, there is no urinary symptom.
Yes, ma'am.
Right. So, what does it indicate? That means the anterior compartment effect is not significant.
Yes, ma'am.
She'll have a mild cystocele. The picture what you have put also in the end looks like it is basically a cervical descent, uterine descent, and not much of anterior relaxation also. Right?
Okay. Yes, ma'am.
Yes, cystocele is not very predominant over here. It's just cervix lying outside. Okay.
Yes,
if there is a big cystocele, then they'll have all possible urinary symptoms.
Okay.
Otherwise, this is looking like just a third-degree uterine prolapse without much vaginal relaxation. Okay.
Okay. Yes.
Okay. So, what would have led to prolapse in this lady then? What level of delancey is affected here? If there is not much vaginal relaxation, only uterine descent is there, it means that which level of delancey is affected?
Apical, the first delancey level 1.
Level 1, that is introsacrals and this thing. Tell me some obstetric factors which will lead to damage of this level.
Yes, ma'am. Ma'am, birth trauma, like
ma'am, not a matter of everything is birth trauma only in obstetric factors. I'm asking you.
Ma'am, fundal
factor.
Ma'am, fundal pressure while trying to deliver the placenta.
No, fundal pressure while delivering placenta. Where is fundus? It's Creed's method of placental delivery. Okay.
Okay. Okay.
You keep on pushing the fundus down like this to deliver placenta. It's one of the things. Fine. I think we are done with the timing. Okay.
Yes, ma'am.
Thank you. Thank you.
Yeah.
Thank you, ma'am.
Yeah. Good, Padmavathy. And our next participant, that is sixth participant, is Ms.Kruthi. She is second year MBBS student from Navodaya Medical College, Raichur. Okay. Welcome, Kruthi.
Thank you.
All the best.
Good noon, sir. Good noon, ma'am.
Share your screen and start.
Yes, ma'am. Yes, ma'am. This is. Ma'am, is my screen visible now?
It's visible, but can you make it full screen?
Yes, ma'am.
Yeah.
Yes, ma'am.
Go on.
Good noon, ma'am. This is Kruthi Kulkarni. I'm a second year medical student from Navodaya Medical College. Today, I'm presenting a case of a lady named XYZ, who is of 18 years old, who is a student by occupation and is pursuing second year PUC. She belongs to upper middle class, and her date of examination was on April 9th, 2021. Her LMP was on July 9th, 2020, and her parity index is G0, P0, L0. Chief complaints were absence of periods since 9 months, and she had irregular periods since menarche, and there was excessive facial hair growth. History of presenting illness. Patient was apparently normal until 9 months ago, and then she started experiencing amenorrhea. She had irregular menses since menarche, that is for past 4 years, and also she suffers with increased facial hair growth past 7 months. Patient gives history of stressful life with no exercise, and she is sexually inactive. There is no history of fatigue, cold sensitivity, constipation, swelling in neck. There is no history of palpitations, anxiety, and diarrhea. No history of galactorrhea or weight loss. There is no history of fever, chronic cough, and night sweating. There is no history of burning or increased frequency of micturition. Menstrual history. She attained her menarche at the age of 14, and her menstrual cycles last for 7 to 8 days, which comes once in 5 to 6 months. She has irregular menses since menarche, and the number of pads she used are 2 to 3 pads per day. There are no clots, there is no dysmenorrhea, and her LMP was 9th July 2020. In past history, there is no history of diabetes mellitus, hypertension, asthma, or tuberculosis. There is no history of previous surgeries, no history of allergy to any drugs, and there is no history of any drug intake. Family history, her elder sister suffers with PCOS. And her personal history is she is a pure vegetarian with good appetite, having adequate sleep. Her bowel and bladder are normal and regular. No history of substance abuse. She's unmarried and sexually inactive. Summary, 18-year-old female suffers with 9 months of amenorrhea and increased facial hair past 7 months. Her LMP was on July 9th, 2020. She attained her menarche at the age of 14, and her periods are irregular since then. She has delayed cycles of 5 to 6 months and bleeding for 7 to 8 days, soaking 2 to 3 pads per day. General physical examination. Patient is conscious, cooperative, well-oriented to time, place, and person. Patient is moderately built and nourished. Pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema are absent. Head-to-toe examination. There is thinning of scalp seen on frontal aspect. She has acne on face. There was mild hirsutism seen with Ferriman-Galvez score of 12. Thyroid enlargement was not seen. Breast, there was no secretions or masses present, and there was acanthosis nigricans seen present on the nape of neck and inner thighs. Vital cells signs are all normal. Anthropometry, her height is 170 centimeters, weight is 58 kgs, her BMI is 20.1 kg per square meter. Her waist circumference is 80 centimeters. Systemic examination seems normal, that is CVS, there is yes1, yes2 sounds heard normally with no murmurs. CNS, there is no focal deficit, higher motor functions and reflexes were present. Respiratory system, normal vesicular breaths were heard. Thyroid examination, there was nothing significant, and breast examination, there was no galactorrhea. And per abdomen examination, on inspection, shape and location of umbilicus is normal, there was no scar seen. On palpitation, no tenderness was elicited and no organomegaly was seen. Palpation, sorry ma'am, palpation. On percussion, nothing significant was seen, and on auscultation, normal bowel sounds were heard. Summary, here is a female of age 18 years suffering with amenorrhea for 9 months and increased facial hair growth. On examination, it was found that there was frontal alopecia, acne were seen, mild degree of hirsutism with Ferriman-Galvez score of 12. Acanthosis nigricans were appreciated on neck and inner thighs. She had all the vitals normal, and she has central obesity. Differential diagnosis, I mostly feel it is a case of PCOS. Also, it could be adult onset congenital adrenohyperplasia. Pregnancy can be ruled out based on history. Thyroid issues could be ruled out because there was no cold, insensitivity, swelling in neck, and fatigue. Due to the presence of hirsutism, hypothalamic factors, and other secondary causes of amenorrhea could be ruled out.
Okay, fine, good. Second year student,
Yes, ma'am.
Okay.
Yes, ma'am.
I really don't know how much you'll know about endocrinology now. Anyway, let's go back to your presenting symptoms, please.
Yes, ma'am. Yes, ma'am.
Okay. No, go to the presenting symptoms. Just the chief complaints.
Yes, ma'am.
Almost like, yeah. So, if any person comes with 9 months absence of periods, what do you call that?
Amenorrhea.
Secondary amenorrhea. She is
Yes,
menstruating previously, right? So
Yes,
you have
ma'am.
two entities, primary amenorrhea and then
Secondary.
secondary amenorrhea.
Yes, ma'am.
What could be the causes of primary amenorrhea?
Ma'am, it could be Mullerian regression.
Mullerian agenesis.
Sorry, Mullerian agenesis, or some genetic defects, or
Chromosomal abnormalities like Turner
yes,
syndrome.
ma'am.
Okay.
Yes, ma'am.
Basically,
Androgen
we
insensitivity.
decide whether it is looking like hypogonadotropic or hypergonadotropic. Okay, so we look at that issue and then we will go on with the man. But you should know the common causes of primary amenorrhea because that's a very common thing. 16 years of age, all secondary sexual characters are well developed, but she's coming with primary amenorrhea. You will think mostly of some problem with the uterus, like absence of uterus, or there is any outlet obstruction.
Yes, ma'am.
The common, very easily treatable condition is
I'm not sure.
patient comes with cyclical pain, but there is no bleeding even at 16 years of age. Otherwise, sexual characters, everything is fine. Breast development is good. Axillary hair is good. Everything is good. What will you think?
Concealed
some kind
problem.
of
Genetic.
What is
Yes,
that?
ma'am. Cryptomenorrhea.
Where do you see this cryptomenorrhea? What's the common cause of cryptomenorrhea? Imperforate hymen. Okay.
It could be acquired or genetic. Yes, ma'am.
Just give an incision on the hymen and open it, and it's done. The treatment is over for that particular girl. Okay.
Yes,
so like
ma'am.
that, there are some very common, easily treatable conditions. Some of them are extremely difficult to treat. Some of them are like not possible to do anything, not possible to help them except for hormonal supplementation in primary amenorrhea. In secondary amenorrhea, like we start classifying them as secondary amenorrhea once they cross 6 months of amenorrhea.
Yes, ma'am.
Generally, nobody waits till this long. They'll come
Yes.
to you once 3 to 4 months. They don't have periods. They will come and approach a doctor. They'll take some kind of withdrawal bleeding and they will go on. Okay. So can you describe her cycles? How were it before 9 months?
Ma'am, they were menorrhagic. It was lasting for 7 to 8 days, ma'am.
And comes once in how many months?
5 to 6 months.
5 to 6 months. Since Manal, she's been having pattern like this, right?
Yes, ma'am.
Okay. So what causes this? What is the problem in
anovulated cycles, I suppose.
They're basically anovulated cycles. See, in a perimenopausal woman also will have anovulated cycles. Agreed?
Yes, ma'am.
But the anovulation in post-menarchal girls and the anovulation in perimenopausal women is entirely different.
Yes, ma'am. It is because of decreased gonadotropin in the beginning.
In the beginning, it is because of immaturity of the HPO axis.
Yes, ma'am.
Okay. The most important differentiating factor is there is not much estrogen here in post-menarchal girls, but in case of premenopausal women, perimenopausal women, there is estrogen preponderance.
Yes, ma'am.
Okay. So any excessive bleeding, AUB, which occurs in young girls, is treated basically with estrogen.
Yes, ma'am.
Okay, but we avoid estrogen in perimenopausal women. Okay.
Yes, ma'am.
Why do we do that? What is the problem with estrogen? If you give only estrogen to a woman, what will happen?
It will increase LH and decrease FSH.
Okay. I think I really don't know. Second year student, how will we go ahead with discussion of such a complicated case? It's not even some simple case you've taken. Anyway, okay. So PCOD is a condition which is got a very long-term effects. Tell me what all problem this girl can have.
Ma'am, she can have diabetes mellitus, hypertension, dyslipidemia, which could further lead to heart diseases like coronary artery disease, obesity, etc. Ma'am.
Okay. So metabolic syndrome is what we call it as actually. All these things what you described are typically features of metabolic syndrome. That is one entity. Other than that,
cancers, breast cancer and endometrial cancer.
Gynecologist will worry about something else also in this lady. What's going to happen? Before even she becomes old enough to develop malignancies and all these things, infertility. Most important is inability to conceive.
Yes, ma'am.
Okay, because they're not ovulating. Okay, the basic problem is there is a lot of hormonal disturbances with androgen preponderance in PCOD. Okay, it will lead to luteinization of all the follicles, so they won't be able to ovulate at all. Okay, so generally these girls will come with problems like this. Okay, irregular cycles. Okay. Hirsutism, acne, frontal balding. Okay, these are the typical symptoms. Case is taken very well. We have done a good job in that. You investigated well how the women will present, and you've given a proper picture. But how are we going to treat them? How are we going to investigate them is what is important for us. Will you be able to discuss that, Kruthi?
Yes, ma'am. Investigation, we could go for serum TSH to rule out thyroid issues. Okay. We can also go for serum prolactin to rule out prolactinemia. We could next do with 17-OH progesterone to rule out adrenal congenital hyperplasia. And we could see the levels of LH and FSH. Usually the ratio is increased. And we could also see USG, mainly because it shows more than 12 follicles with a size of more than ovarian volume increased to more than 10 cubic centimeters. And also there will be more, the size will be around 2 to 9 mm.
The problem with PCOD is the doctors who diagnose this condition will tell the patient that you have cyst in the ovary. Okay.
Yes, ma'am.
So they won't mention that, they're very tiny cysts, less than 1 centimeter in diameter, but there are multiple of them. So they'll only think that it is some kind of mass effect over there.
Yes,
it's not a mass effect at all. It's not an ovarian cyst at all. They are polycystic. Okay, they're just cystic. Cystic means cyst kind of things are there, but they are not big enough to be quantified as cyst actually. Okay.
Yes, ma'am.
So they're peripherally placed, small, less than 1 centimeter cysts of more than 9 in number is what is the recent Rotterdam criteria for diagnosing PCOD by ultrasound. Okay.
Yes.
What's most important for us is the clinical diagnosis. This oligomenorrhea, okay, androgen excess leading to hirsutism. Those things will help us in diagnosing PCOD rather than ultrasound. We only confirm our diagnosis by doing an ultrasound to look for this typical picture of polycystic ovaries.
Yes.
So you have done all this, you know that this is indeed a case of polycystic ovary. How are you going to manage that? She has some sign of hyperandrogenic features also.
Yes, ma'am. Hirsutism, acne.
Yes, irregular cycle. So what should be the most?
Firstly, weight loss should be recommended, ma'am. Weight loss and lifestyle changes.
Okay. That is most important in the PCOD. And it's an ongoing thing. It is not like 6 months you diet and do exercise, then you'll be fine. It is not like that. For the whole life, they have to be careful about what they eat and how much they exercise and all this stuff. Okay, that has to be impressed upon the girl. Again, this is a condition which cannot be treated. We can only prevent problems occurring due to the hormonal imbalance over here. That's all. Okay.
Yes,
so what are you going to do for her irregular cycles?
We can give OCP treatment, ma'am. Oral contraceptive.
What kind of OCP will you use?
3rd and 4th generation, which can also help in reduction, which are also anti-androgenic in their action, which helps in reduction of hirsutism.
Okay. See, basically, generally, what do OCPs contain? I think this is an easier question for you.
Progesterone and estrogen. Usually progesterone, but sometimes progesterone plus estrogen.
Yeah. Initially, what's available under Government of India, the free of cost Mala D, Mala N. Estrogen content is same in almost all the pills. Okay. The what changes is the progesterone, the type of progesterone what we use. Okay, estrogen only the dose differs, 30 mics, 20 mics, 15 mics kind of thing. It will keep on coming down with higher generation. But what's important is the progesterone is what is used is how is the nature of the progesterone. Okay. Commonly used progesterone in these cheaper or freely available pills is levonorgestrel.
Yes, sir.
Or norgestrel. Okay, they are the ones which have a lot of androgenic side effects actually. So you should not use those pills in this girl. We will be using progesterones with lesser. Can you name some progesterones with
Desogrel, I suppose.
Desogestrel.
Desogestrel.
Or drosperinol.
And yes, ma'am.
Drosperinol. These are the 2 progesterones which are useful. But in this girl who's already manifesting with some kind of androgen excess, it's better to give something which is
anti-androgenic. Yes, ma'am.
Name a hormone.
Flutamide or spironolactone.
No, we don't use those with OC pills, right? Combined OC pill when you're using, you will rather use something which is a progesterone kind of thing, but it is not having any androgenic, but rather has an anti-androgenic, cyproterone acetate.
Yes, ma'am.
Cyproterone acetate along with estrogen is available as a pill, Crimson. Okay, so that's what we will give this girl for at least 3 to 6 months. Okay, and then we'll ask her to modify her lifestyle. Okay.
Yes, ma'am.
Once her androgenic symptoms come down, we can shift over to other pills. Drosperinol or desogestrel containing pills are what are used. Okay, how old is the patient? 18 years, right?
18 years, ma'am.
Okay, so 18-year-old girl, obviously she has a long way to go at. So you can use these pills on and off. You keep on giving these pills to her. Every year she can use for 6 to 7 months and then have a pill-free period and then again start till she finishes a family. How are you going to manage her infertility? once she gets married, you know that she's going to have trouble conceiving. PCOS is a big problem for infertility specialists. Okay, so how
we can use of letrozole or clomiphene.
Use ovulation. That's what you mean, right?
Yes, ma'am.
Clomiphene citrate or letrozole for ovulation induction. Most of them do not conceive with that. If they are really this bad PCOD right from adolescent, she's going to have a lot of trouble conceiving until unless she has, reduced her central obesity, adopted a very healthy lifestyle, and all this stuff. She's going to have a lot of trouble conceiving. Okay. So what are the other drugs we can use for conception other than letrozole and clomiphene for ovulation induction?
I'm not sure.
No idea. It's okay. No problem. Okay. So that is how we go about in PCOD cases. Basically, we generally see that. Okay. So how are you going to manage her excess bleeding now? She has menorrhagia with some irregular cycles, right?
Yes, ma'am.
Give me a moment. There's a call. Hello. Yeah, go on.
Yes, ma'am.
What was I telling you?
How to decrease menorrhagia, ma'am.
Yeah, how do you take care of menorrhagia in this girl?
I'm not sure, ma'am.
Yeah, when you use OC pills, it will be taken care automatically. That's all. I just wanted you to know that other than regularizing the cycles, OC pills will also control the problem of menorrhagia in this girl. Okay?
Yes, ma'am.
So OC pills is a wholesome treatment for this girl, actually. Okay.
Yes, ma'am.
So that's what we're going to prescribe her, and that is what is going to take care of all her problems. Okay.
Yes,
Let's assume this girl had only menorrhagia, not irregular cycles. Okay. It's called as puberty menorrhagia. Like, she's 16 years of age and she's come with only excess bleeding, no menorrhagia. What all will you think of? Kruthi, what are the causes of puberty menorrhagia other than the anovulation, which occurs due to immaturity of the HPO axis, where the treatment is going to be again high dose of estrogen containing pills? That's all. Okay. Any other cause you know? Why should adolescent girls should have menorrhagia right from menarche?
Not sure, ma'am.
Okay,
No.
it's okay, no problem. I think we'll close this session. Thank you, Kruthi.
Thank you.
Yeah, can we have the next candidate, please? Shashank?
Good afternoon, ma'am. Am I audible?
Yeah, you're audible. Very well audible. Share your screen, please. Again, mass descending for vagina. Shashank, where are you?
Shashank?
Unmute yourself. Shashank, unmute yourself. You're not able to? Organizers, please take care of that.
Hello.
Yeah, what happened?
Ma'am, wasn't I audible all this while?
You are not audible, you are not visible. Now only you are visible.
Oh.
Share your screen. Go to the first slide. Okay. Put on your audio and video.
Hello.
Yeah.
I had network issues, ma'am. Shashank?
God. Ma'am, am I audible now?
Yeah.
Hello, ma'am.
Yeah, yeah.
Okay. I'll start with my presentation now. I'm presenting a case of a 68-year-old female who hails from KGF. She is not educated and she works. She used to work as a laborer. She belongs to a lower middle class family according to modified Kupuswamy scale. And she is a multi-paras woman with the obstetric score of para 5 living 5. She came with the complaints of mass sizzling per vagina since past 2 years and difficulty in initiation and incomplete voiding of urine since past 2 months. History of presenting illness. She is a multigravida who was apparently normal 2 years ago when she noticed mass per vagina, which was insidious in onset. It was noticed around 2 years ago when she had an episode of cough, and it was aggravated on lifting heavy weights and straining. It spontaneously reduced on lying down and by manually pushing it in. It has progressed since then to the current size. Since past 2 months, she is having difficulty in urination. She is having difficulty in initiation of urination and she feels the voiding is incomplete. She can initiate voiding after manually stenting the mass. No history of urine incontinence on coughing or straining. No history of burning micturition. No difficulty in defecation or passage of hard stools or bleeding per rectum. No history of bleeding per vagina. No discharge per vagina. No history of pain abdomen. No history of backache. No history of chronic cough or chronic respiratory disorders. No history of cigarette smoking. Her obstetric history reveals that she is a multiparas woman with a married life of 50 years. And to summarize her obstetric history, she is having 5 children and all of them were full-term vaginal deliveries and all of them were conducted in her home and were assisted by local dye and no known complications during labor, known instrumentations. All the children were breastfed till around 1 year and they were immunized in a government hospital. Menstrual history. Patient attained menopause 16 years ago at the age of 52. She had her menarche at the age of 14 years and her cycles were of 28 to 30 days interval with a flow of 3 to 4 days. She used to use 2 to 3 clots per day and no history of passage of clots or dysmenorrhea. She is a known hypertensive since past 5 years. No history of asthma, tuberculosis, diabetes, no allergies or previous sustenance. No family history, no significant family history. Her personal history reveals that she consumes a mixed diet. Her appetite is normal. Bowel habits are normal. Bladder habits as described above. Sleep is adequate and she doesn't have any addictive habits. The patient was conscious, cooperative, well-oriented, time-placed person. She was examined after obtaining her consent in adequate lighting, privacy, and dorsal position in presence of a female attendant. Her vitals were normal. General physical examination was normal. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema. Spine, breast, and thyroid were normal. Abdominal examination. On inspection, the abdomen was scaphoid. Umbilicus was central. All areas moved equally with respiration. No scars, sinuses, or dilated veins. Earlier orifices were intact. No divarication of erecti was noted on leg raising. On palpation, it was non-tender. No rise in temperature. Abdomen was soft. No palpable mass. No organomegaly. On percussion, a tympanic note was heard in all areas. Liver dullness was present at the left fifth intercostal space. Auscultation, bowel sounds were heard. To summarize, abdominal examination is unremarkable. Per vaginal examination, only inspection was done, ma'am. Mass protruding per vagina outside the introitus. No ulceration or bleeding over the surface. Discharge was seen, watery in consistency. Mass appeared to bulge on straining, and the leading part was cervix. On coughing, the mass protruded out. No hyperpigmentation noted. And I would like to do a bimanual examination, per speculum examination, per rectal examination to complete my per vaginal examination. Examination of other systems were normal. To summarize, 68-year-old multiparas woman presents with complaints of mass per vagina since past 2 years, aggravated on straining and relieved on rest, associated with difficulty in initiation and incomplete voiding of urine since past 2 months. She is multiparas with the obstetric score of para 5 living 5. All deliveries were full-term vaginal, conducted at home, assisted by local dye with no apparent complications during labor. She is a known hypertensive since past 5 years, is on medication for the same. On inspection, could see a mass protruding per vagina, which bulged on straining, and the leading part was cervix. Provisional diagnosis, postmenopausal multiparas woman with 3rd-degree uterovaginal prolapse.
Shashank,
yes,
in exam, what happens? Sometimes some students will share cases and this is what happens. We'll have the same case being discussed 3-4 times. So examiners tend to get bored and they'll ask you some other question. Okay, are you prepared to answer some other question?
I'll try my best now.
Okay, you are 4th year or 2nd year?
4th year.
Exam going student now. Okay. One of the other common cases which we will keep for undergraduates will be a case of postmenopausal bleeding. Okay.
Okay.
Postmenopausal bleeding, how will you evaluate?
Postmenopausal.
68-year-old lady, instead of prolapse, she's come with postmenopausal bleeding. That's the only difference. Okay. So
Okay.
tell me, para 5, life 5, 68-year-old with postmenopausal bleeding for evaluation is a diagnosis.
Okay. Postmenopausal bleeding is like it can be associated with malignancies like endometrial carcinoma.
What's the most common cause of malignant postmenopausal bleeding in our country?
Endometrial carcinoma.
We are not in US, we're in India, right?
Yeah. Cancer cervix.
Cancer cervix. Endometrial cancer is very common in Western countries. It's a disease of affluent countries. Okay.
Yes, ma'am.
They have conquered over carcinoma cervix. How did they conquer over carcinoma cervix? How did they conquer over carcinoma cervix? Developed word?
Ma'am, one is by vaccination and by
screening. Vaccines have come only recently, right?
Yes, ma'am.
So they have not helped them in conquering. What has helped them in conquering is?
Routine screening and
okay, a very well organized screening system is what helped them to conquer over invasive cervical cancer. So they are still in their burden of endometrial cancer is much more than cervical cancer now. But in our country, cervical cancer is still leading cause of gynecological malignancy. The most common gynecological malignancy is cervical cancer. So if you have a postmenopausal bleeding in a postmenopausal woman like this, you will think of cervical cancer rather than endometrial cancer first. Obviously, we have to think of endometrial cancer also. Okay. But it's more important to know that in our country, CS cervix is more common. Okay. So if you think of CS cervix, will this patient fit into that? Para 5, life 5, postmenopausal multiparous woman?
Yes, ma'am. Multiparity is one of the risk factors for carcinoma cervix.
Low socioeconomic status.
Low socioeconomic status, old age, and multiparous status.
Okay. Tell me that only risk factors for endometrial cancer?
This thing, endometrial cancer is hyperestrogenic condition. Any like late menarche, early menopause. I mean, and
early menarche, late menopause.
Early menarche and late menopause. Then the prolonged use of OCPs and estrogen containing pills, ma'am, and
OC pills contain estrogen, you know that, na? But will they lead to increased risk of endometrial cancer?
Ma'am, only estrogen containing pills will lead to endometrial
Nobody
cancer.
gives only estrogen containing pills. Okay, so don't worry about that. Unopposed estrogen. In HRT, if the patient is taking over the counter only estrogen, they can have this. Okay.
Yeah.
Otherwise, no doctor will prescribe only estrogen containing unless they are quacks practicing gynecology. Okay. So typical description of a patient with endometrial cancer is going to be a postmenopausal lady or a perimenopausal lady who's nulliparous, who's obese, okay, who's got diabetes, hypertension, the metabolic syndrome kind of picture. And there is history of chronic anovulation, like irregular cycles during the menstrual life and all this stuff. That is a typical history of endometrial cancer. Okay, doesn't matter. Now you tell me, how do you approach this patient now? Examination onwards.
Postmenopausal bleeding. Okay.
It's so difficult. Then forget it. Shashank, forget it. I don't want to trouble you. Let's go back to prolapse again. You would have prepared for prolapse. Fine. We still have another 11 minutes left, so we can discuss prolapse itself again. So this lady is, you think it is genital prolapse. Okay, what classification did you use to classify her as third degree uterovaginal prolapse?
Ma'am, I used Shaw's classification.
Okay, tell me what is Shaw's classification?
Ma'am, in Shaw's classification, we take the reference point as the introitus.
Okay.
And it's for uterocervical prolapse, and it's divided as uterocervical and vaginal prolapse. Under uterocervical prolapse, it is divided into various degrees. First degree is cervix is protruding into the vagina. Second degree is cervix at the level of introitus.
Cervix is in the vagina only. No, what is protruding into the vagina?
Ma'am, the descent of the cervix into the.
What is the normal position of external os?
At the level of the ischial spine.
So cervix descends below the ischial spine, but it does not come up to the level of introitus is first degree prolapse. Then.
And second degree prolapse is at the level of introitus. Third degree is beyond the level of introitus. Fourth degree or procedentia is the entire
uterus below the level of introitus. This is Shaw's classification. Are you aware of any other classifications?
Another objective method is POPQ classification. Pelvic organ prolapse.
Can you expand POPQ?
Pelvic organ prolapse quantification.
Okay. It's an objective way of classifying prolapse. Okay.
And here we take this thing hymen as the reference point.
Reference level, and we have different measurements points which we have to measure. Fine, that's fine.
Yeah.
That
one more is Baden-Walker halfway classification. Again, here hymen is taken as a reference point.
Any other classification other than these three? These three are the most commonly used. Okay, there is another classification called as Malpass. Ever heard? It's a very old classification, but it dictates the management. You tell the diagnosis, you know. See, for example, in this case, Shaw's classification, you're telling 3rd degree uterovaginal prolapse.
Yeah.
Okay. But we can't dictate management depending on this. We need to know about the patient's age, her parity, okay, many other things. Is she fit for surgery? Vagara, vagara, all those things we'll need to know. So it is not a management dictating classification. It will only tell you. But this is the most commonly used classification, Shaw's. Okay. There is another thing called as Jeffcourt's classification. Heard of it?
No, ma'am.
These are the different classification system, but you told Baden-Walker and PopQ and this is fine. Good enough. So, what else we didn't discuss in prolapse from that time? Okay. So this patient is come to you with prolapse, multiparous lady. How do you want to manage her now?
First, I would like to do certain investigations. Okay. A complete blood count, then random blood sugars and other routine investigations, urine culture and sensitivity. And she is having urinary complaints. So I would like to do a USG for hydronephrosis. And
3rd degree prolapse, man. Why do you want to do a USG for hydronephrosis? This is a problem when we have repetition of cases. In exam, we don't allow other students to sit and listen to us, right?
Yeah.
So it's not very easy to discuss the same case because you've heard already what all questions I asked and you'll go back to the same thing, right? You get biased like this also. I told specifically that in procedentia only we'll do an ultrasound there, a long-standing procedentia to look for hydronephrosis. Otherwise, there is no role of ultrasound in prolapse until unless you have some abnormal finding in the examination. Okay.
Yeah.
Go on.
And then I would like to take a pap smear. She is a old lady with.
Okay, you've taken a pap smear. The report is HGSIL. What do you do?
Ma'am?
The report comes as HGSIL, high-grade squamous intraepithelial lesion. What do you do next?
Not sure.
She requires a surgery anyway, right? You told you'll take a pap smear. So tell me what if some abnormal report comes on pap smear?
If abnormal report comes, then we'll have to take her for this thing, surgery.
No. We don't directly, but then why should we do a pap smear at all? Anyway, we're going to do surgery. We're going to remove the uterus and cervix. We're not going to leave cervix behind and remove only uterus like an abdominal hysterectomy, right? We're going to remove cervix also. Then why do we need to do a pap smear?
Ma'am, one thing is you'll get to know this thing. I'm not sure.
You're not sure. Okay, so we do pap smear because if it is coming as a high-grade lesion like this, we need to do a colposcopy and take a biopsy, okay, from the most abnormal looking area in the colposcopy. And if that shows evidence of invasion, then a simple hysterectomy is not enough for her. We have to go for extended hysterectomy like radical hysterectomies and all. That is why we do a pap smear. Okay, we need to evaluate before we take up. Okay. Otherwise, there is no point doing a pap smear, right? If you're not going to act upon the result, there is no point. Fine. So you've done a pap smear, you have done all the investigations, everything, and she's fit for surgery. Okay. So what surgery are you going to do?
Ma'am?
What surgery will you do for this patient?
In this case, I would like to do a Ward-Mayo hysterectomy.
Ward-Mayo's hysterectomy. Okay. Is hysterectomy essential for the treatment of this condition?
It's a 3rd degree.
Patient wants to preserve her uterus. She wants to conserve, not this lady, some other lady, 38-year-old lady. She wants to conserve her uterus. Is there any surgery where you can conserve the uterus?
We can do the this thing, Manchester operation.
Manchester surgery can be done for conserving the uterus. So it's not like hysterectomy has to be done. Okay, please remember that. If the necessity is there, we can conserve the uterus also in case of prolapse. Okay.
Yeah.
How do you demonstrate an enteroseal clinically?
Enteroseal, one thing can be upper rectal examination.
First you tell me by speculum, how do you say whether enteroseal is there or not there?
Ma'am, it will be transilluminant swelling, ma'am.
Where will you put the light from? Transilluminant swelling. Huh? You can't put a light. No, where are you putting the light to get transillumination? Right.
Yeah.
So in speculum, when you're doing the speculum examination, how do you say there is an entrocele?
Ma'am, it is
Go back to the examination part. Did you let me see if you've written it down and you're not able to do it?
Ma'am, we were not allowed.
That's okay. That's okay. No problem. You're not expected to do it, so it's okay. So in speculum examination, you will retract the anterior wall and cervix up with the speculum. Put two fingers on the posterior wall. If the bulge occurs in the upper 1/3, it is entrocele. Middle 1/3 is rectocele. You've been taught this, right?
Yeah.
It might didn't come out. Got confused.
Yeah.
Okay, so examination, you should know whether you're expected to do or not. You should know if you're asked to do, how will you diagnose all these things.
Yeah.
Okay. So how will per rectal examination help you? Would like to do a per speculum and per rectal every time.
Ma'am, on per rectal examination, if you feel the swelling on the tip of your finger, it will be an entrocele. If you feel it on the pulp of your finger, it will be a rectocele.
You won't feel. The rectocele, you're not going to feel on the pulp of the finger. It will move away from your finger when she strains.
Yeah.
Right? But something comes and hits the tip of the finger, it is coming from above and this thing. What is the content of an entrocele?
Ma'am, the pouch of Douglas may or may not have intestines.
Content means something inside the pouch, right? So it is basically small bowel. Small intestine is the content of, and that's why it's called as an entrocele. Okay, why is this information important for us is that if you're not careful, you may injure the small bowel also when you're opening the pouch of Douglas, because it contains all these loops of small intestine over there. Okay.
Yes,
what else it can cause complication during surgery? What else it can injure?
Anteriorly bladder and urethra, posteriorly rectum and the gut and the bowel, small bowel.
Small bowel is for enterocele and you can injure the rectum. Okay, can you injure ureter?
Yeah. Yes, ma'am.
If you want to injure, you can injure anything actually, but not tonsils and all when you're doing a vaginal surgery. Ureters are just nearby, right? If there is slipping of the uterine vessel pedicle, and if you go on clamp lateral to the uterine vessel pedicle, you can easily injure the ureters also. Okay, but not very common. Common is bladder injuries, rectal injuries. Okay, and small bowel if you're not being careful while opening the pouch of Douglas. Otherwise, injuries are not very common. We don't generally see so many injuries over here. Okay, how do you avoid? Forget it. I think it's beyond your purview actually. So, for a patient, you have done a surgery, ward Mayo surgery. Okay, within the first 24 hours, she bleeds. What do you call that?
Reactionary hemorrhage.
What are the causes of reactionary hemorrhage?
Slippage of the sutures or ligatures.
Slippage of ligatures. Good. So, how do they present?
Ma'am, they'll have massive bleeding. They'll have
massive bleeding where?
Ma'am, in the pelvis.
Bleeding for vagina?
No, in the they'll have bleeding in pelvis.
What is bleeding in pelvis? I don't understand.
Ma'am, reactionary hemorrhage because of the slippage of the ligatures, they'll have internal bleeding.
Internal bleeding, okay.
Yeah.
So
and then they'll be hypotensive, and they'll have weak pulse.
They'll look pale, they'll look dehydrated, they'll have tachycardia, they'll have hypotension. They will have a suprapubic bulge which is not relieved on catheterization. Okay. Generally, this woman will have a catheter in situ. Okay. Catheter will be draining, but there'll be a bulge which looks like as if catheter is blocked. You rule out a catheter block, even then the bulge persists. It means it is some collection over there. Okay, in the pelvic area where you have done the surgery. So that's how it goes on. Okay. In case of TAH, you have done a total abdominal hysterectomy. Their patient has reactionary hemorrhage. How will they manifest?
I'm not sure, ma'am.
Same way. The general things is going to be same. Hypotension, tachycardia, pallor, vagara, vagara. For abdomen, they'll have free fluid in the abdomen. Because though there the pedicles are lying in the peritoneal cavity. In case of vaginal hysterectomy, pedicles are lying in a confined space outside the peritoneal cavity. We do extra peritoneation of pedicles over there, so they won't generally manifest with pneumoperitoneum. They manifest with swelling, where it forms a kind of hematoma around the bladder. Okay, so that is how you diagnose the problem in post-op periods. Okay, chalo bacha, bye. Thank you.
Thank you.
Ishan? Is Kishan around?
Yes, madam. Yes, madam. Thank you.
Hi.
Madam,
yeah, tell me.
Wonderful. It was not like a competition or a normal session. It was more of a learning session for all the participants. Wonderful. You never leave any opportunity to teach. You never miss. Each and every point you make sure that students learn properly and clearly.
Okay.
What we like the most is the way you explain, ma'am. Things so nicely, crystal clear explanations. Okay. Even now, being a surgeon, I learned a lot of things from you newly. And sometimes I feel I made a mistake. I should have taken gynecology because at least, your explanations are so nice.
CPVS would have lost a good surgeon, Kishan, if I had taken gynecology. UBS, CPVS surgeon.
Okay, really, I loved. In fact, at the end of the internship, among all the subjects, the subject I loved the most was OBG, ma'am.
Why you didn't take up OBG, man? Nobody takes up OBG. Okay, my students, nobody.
Nowadays, the trend has no. I don't agree. Nowadays, trend has been changing. Most of the boys are taking up OBG and girls are taking up ortho and surgery. From my batch only, from Bengaluru Medical College, nearly 7-8 boys have taken up OBG. Okay. They're doing really well. And 2-3 of them are your students only. Sri Bharti and Mangala, they're all your students only.
Oh, Shivarthi is okay. Yeah. Shivarthi is my very favorite
my co-CR, my batchmate, very good friend of mine.
Okay. Nice.
Madam, can we have third, second, and first? Like all
actually, there's a tie for first slot. I just
first slot only one. Second slot you can make a tie.
First slot only one now. Okay. Difficult one.
No issue, ma'am. You can announce for 2 first and 1 second and 1 third. You can announce.
That's okay. I don't want to make any changes
because whatever we want to encourage everyone. Our intention is not to make any competition among them, just to encourage them to prepare them for the final exam.
All of them were
their
good,
confidence
that.
levels.
Only thing, Kruthi was too young to answer the subject-related questions, so I can't blame her for that. She's only second-year undergraduate.
Okay.
Otherwise, everybody did a good job. They've got comparable marks only. Okay. The first slot is for Vishwa and Preethi. Both of them have got 37 out of 50.
Vishwa and Preethi. Okay, ma'am.
Yeah. Okay. The second slot is for Neha.
Neha. Okay.
With 36. Third is for Shashank with 35.
Wonderful, ma'am. Wonderful. So they'll be getting cash prizes and e-certificates.
Who's sponsoring them? You only.
I'm only, ma'am. I'm only here. Every week we have all the subjects, ma'am. We done with medicine and surgery.
Yeah, you told me.
Gynecology and obstetric we'll have separately. Okay. And then we'll have pediatrics and all the other subjects also. I just want to encourage them, ma'am. Like if they exposed to examiner like you.
Yeah. Sure.
They'll all be getting the first 3 positions will be getting cash prizes, and also all the finalists will be getting e-certificates.
Okay.
With your signature autograph on it.
Okay.
With madam's autograph. And congratulations all the participants.
Yeah.
And among today's presentation, those 4 were best. It's not that others were not good. All of them. I was also listening. All have done equally good. For today's presentation, those 4 were better than others.
I wish there were no 4 cases of prolapse. It was really difficult.
I'm sorry, ma'am. Sorry, I thought only 15 minutes discussion. No, so I thought entire discussion will be divided among 3. I'm sorry. And
4, not 3. Okay, 4 prolapses.
Gynecology among UGs, for UGs only there are 4-5 cases, madam. I expected some ovarian tumor and all, but nobody.
Mass abdomen, something should have been there.
Yeah, ovarian tumor expected, but nobody came up to present. But anyway, all the presentations were good, ma'am. I could not eliminate anyone. Ma'am, any good things you have told, ma'am. What are the common mistakes they do and should be avoided? Can you please
I think these guys did a good job, all of them. Okay, only thing sometimes they contradict their own findings. That should not happen. Like per abdomen, they say something, and bimanual they say something. But anyway, as you told, they're not expected to do PV and bimanual over there. So it's okay. Even in JIPMER, we don't ask them to do, but we give them the findings so that there'll be some discussion going on over there actually. So I think it's fine. They did a good job only.
How they answered everything okay, ma'am?
For gynecology, they were very good, man. We don't see. I'll tell you one thing. In undergraduate exams, I expect them to know the basics in obstetrics. That's what is most important for us. Okay. And for other things like in gynecology and all, it's like general surgery for me. If they know when to refer a patient to gynecology, I'll be very happy. That's all.
No. Mainly we see the approach, ma'am. Their diagnosis and management part, we are least bothered.
They don't need to manage the patient. They just need to know
whether approach is proper, history and examination.
Yeah.